policy contributors. I refer ordinarily to stakeholders as a policy contributors. We usually loosely use the term as stakeholders. And I think we've got to ponder the question, how much at stake do you hold in a decision-making processes? I think this morning, that is but one of the issues that we would want to disquisition. Because in the model of our constitutional democracy, we get to learn that there was a deliberate construct which converged two formats of ensuring decision-making processes. And what you will find is that we usually characterize our democratic construct as both representatives but also as participatory. And there must be a level of convergence in everything, and that includes policy formulation, policy assessment, decision-making processes. But often at times, we find that there's a gap in respect of the other element, which is a participatory. And so I think we then regard this occasion as a grand one, because it at least makes an attempt to afford an opportunity to yourselves, as stated policy contributors, to come and collectively reflect with us. South Africa has got a unique model of a governance, where you have got three branches of the state, as you will know. And often at times, a great number of our people make a mistake of confusing roles, of thinking that the legislature, which is parliament, it's one and the same as the executive. It's not. What we loosely refer to as government could be a congregate of your departments, agencies, insulated from the legislative sector. And this is who we are this morning, the legislature, or if you will, a parliament. But of course, parliament can only be legitimated in its overall existence by its linkage to society and yourselves as policy contributors. And that is why we would have thought it necessary that as we reflect, this is a critical subject, we don't do it alone with a government, but we do it in conjunction with your own participation, if you will. Because I suspect amongst yourselves resides experts, pundits, sages in this specific subject. And that is why we thought it necessary that we need to leverage your insights in respect of this specific issues. That forms the basis of our discussions this morning here. But without necessarily getting deeper into the issues, because I think we'll outline the intent or purpose of this session later on. But we just want to appreciate all of you for responding positively, for heeding the call when the legislature reached out. Because the legislature cannot function on its own. A short while ago, you will remember there was a media reportage on the issue of the Tembisa Hospital. And we did a number of media engagements. And in a number of platforms, we are asked a similar question about the overall functionality of the oversight mechanism. And I think I hastened to indicate that oversight could presuppose that there are all functionalities that would enable it to detect everything that happens within the health ecosystem. But unfortunately, there has never been a foolproof system. And the same could be said about the oversight role or mechanism. And so that is why it is mostly important that from time to time, in a structured way, in a meaningful way, we engage with yourselves. So that where there are areas of a blind spots or oversight blind spots, because service delivery happens at the level of our communities, it is almost expected that as the users of the different systems, different facilities, you should also take a keen interest in what happens there and do not await any reaction when things have gone wrong. And so that's the kind of relations we want to foster with our stakeholders. Our door, as we usually say, is always open. You have got a crowd of members here representing different political organizations, but ultimately representing the residency of our province of Gauteng. And so there should be some level of a reliance on them, such that as we converge our efforts, we can pick up on some of these things even before they get to a stage where they are more headful to our own society, if you will. So allow me to appreciate you, having stated that. I know we are joined by several stakeholders. I think I've got a list. I think we've got a list here. I want to do it formally so that it's not a generalized. Yeah, welcome. I know the World Changes Mental Health Care Organization, Well-Being Africa, the SA Federation for Mental Health, Central Gauteng Mental Health Society, the Talisman Foundation, the Witwatersrand Mental Health Society, the South African Depression and Anxiety Group SADAG, Netcare Keso, Lifeline Johannesburg, North Gauteng Mental Health Society, the Six Life Path Health Soweto. I think it's a private mental health facility located in Soweto, if I'm not mistaken. And then the Center for the Study of Violence and Reconciliation, Well-Being Africa NGO, working in nutrition, psychosocial support and skills development, the SA Federation for Mental Health, Advocacy, Human Rights and Mental Health Services, the Freedom Recovery Center, and the National Human Trafficking Helpline. So these are the stakeholders that we had managed to reach out to and responded positively. But of course, in our midst, we are also joined by members of the community who, when they saw the adverts on this specific session, also heeded the call that we also want to present ourselves, render our contributions, and we also really want to appreciate them. But I know there's several other NGOs that may not have been invited formally through this channel, but because Parliament is an institution of the people, you actually do not need any formal invitation to participate in its activities. We also want to thank those of you who would have joined us this morning. Truly appreciate it. I quickly want to deal with. Do we have a standing apologies? Okay. I know we are going to be joined by the MEC of Health in the course of our proceedings. There's a meeting that is happening now with the Premier, and she had indicated that she would likely to join late. I'm not so sure how late, but I'm hoping that it wouldn't be as late as such that she wouldn't hear your contributions. I'm hoping and crossing my finger that she will come in well in time. So thank you very much for for all of that. There could be also several other members. Member Hlope, I see. We had Member Mfikwe who was here. I want to start off by following protocol. Ordinarily, when the legislature goes out into outside of its premises, it declares whichever area is the precinct of the legislature, meaning that the kind of reverence in how we conduct our meeting keeps up with what ordinarily would be the case in the legislature. But having said that, allow me to also introduce the team which constitutes or makes up the Portfolio Committee of Health and Wellness in our province. A very progressive team, a mosaic, if you will, made up of a different political parties, as I had earlier stated. But what you will find is that we function or work in unison. We differ here, we differ there, but ultimately, there's a spirit that carries us to do the work that we do. I'm going to start on my left, and then immediately thereafter we'll follow with the admin support team.
Good morning, everybody. My name is Malazagas Kosana. I serve with pride in this Committee of Health in Gauteng. Thank you.
Good morning. Nice to be here. I'm Jack Bloom, member of the committee. Thank you.
Good morning, everybody. Please excuse me for not standing. My name is Madeleine Hicklin, and I am also a member of this committee, and I love the work that I do. Thank you so much for joining us.
Good morning. Good morning, everybody. My name is Louisa Evans. I'm a member of the committee, and thank you all for coming.
Good morning, everyone. Nondumiso Okas, Committee Coordinator.
Good morning, everyone. I'm Maggie Mukonoto, researcher for the Portfolio Committee on Health. Thank you.
Good morning, everyone. My name is Wakile Nzibande. I'm the Senior Information Officer for this committee. Thank you.
Good morning. I am Tembegile Msomi, the Committee Administrator. Thank you.
Okay, so there we have it. And there are also those gentlemen who are assisting us there. I may not know their names, but you are also welcomed, because we must welcome everybody here. But thank you very much to all of you. I suppose as we open up for discussions, we'll also get to learn about those of you who are here. But I also want to invite the department, because we also have got managers from the department to also just stand up and quickly introduce themselves.
Thank you, Chair. Good morning. I am Pesisi Lepe. I'm the acting COO from the Gauteng Department of Health and Wellness. And just to also indicate, Chair, that the acting HOD, I think she had sent in formal apology through his office. Thank you.
Morning, Chair and honorable members and delegates. I'm Mutumoni Pitsi. I'm the Acting Chief Director for District Health Services and Citibank. Thank you.
Morning, Chair and honorable members. My name is Peter Makola, the PLO to MEC.
Good morning, everyone. My name is Ramatsubane Lekwati. I'm working in the Mental Health Directorate at the Provincial Office, Gauteng Department of Health. Thank you.
Good morning, colleagues. Good morning, Chair. Lebitso ke Monjalefa wa Hamagata. I'm a Chief Psychologist in Citibank District.
Good morning, Chair and honorable members. and delegates. I'm our Msie, acting CEO of Jubilee Hospital.
Good morning, Honorable Chairperson, Honorable Member of Portfolio Committee, all my senior manager. My name is Dr. So, CEO, Mamelodi Regional Hospital.
Good morning, Chair, and honorable members and the delegates. My name is Zakele Zita. I'm the acting CEO of Helen Joseph.
Good morning, Chair, delegates, and honorable members. I am Mariam Edu, Clinical Manager, Helen Joseph Hospital.
Morning, Honorable Chairman and members of the committee and delegates. My name is Gerard Grobler. I'm the Head of Clinical Unit Psychiatry at Steve Biko Hospital.
Good morning, Chair. Good morning, honorable members. Good morning to the delegates and the participants here today. I am Dr. Molelekeng Situnsa. I'm a chief psychologist at Steve Biko Academic Hospital.
Good morning, everyone. Good morning, Chair. Dr. R.T. Motsepe, acting CEO of the hospital.
CEO, come this side. You must also introduce yourself. You can introduce yourself.
Okay. Good morning. My name is Gauteng Muloi, CEO at Gauteng Hospital. Thank you.
Thank you very much.
All right, thank you very much for all those introductions. I hear Dr. Bloom is complaining a bit that you are quite a lot, you know. But it's okay. Can you hear me through this mic? I get a sense that it's not as audible. So thank you very much. Those are all the introductions. And introductions, by the way, are quite important, so that we can account for those who are here, isn't it? But maybe just quickly, as we move on to the third item on our agenda, do we all have the agenda? Yeah, we're going to follow that agenda and we'll try to move as swift as possible so that we afford you more time, because what we really want to achieve with this engagement is to hear you. We don't want to be rehashing what we already know, but we want to hear from yourselves as stakeholders. I think the committee, as most of you, if not all, would appreciate, is an oversight body that oversees the programs of the Department of Health. Of course, it does that through a number of instruments and also scrutinizes the content of some of the programs. And that is notwithstanding its other responsibilities that includes lawmaking, and lawmaking, it could be tertiary as well as a secondary legislation. But with that said, at some point, the committee having undertaken a number of oversight visits to different health facilities, be they tertiary, be they regional, be they district, be they clinics, thought it necessary that we come closer to understanding the broader ecosystem within which the mental health program resides. And of course, that would have largely been informed by some observations about the inconsistency in the structure in which service delivery provisioning as it relates to mental health could be carried at different levels, and it may not necessarily be attributed to the planning methodologies, but just how constraints at different levels could stymie the consistency in application. But if you will, all of you would appreciate that South Africa presents with multifaceted health challenges. But I think of concern is that we've seen the prevalence of mental health presentations in a number of our presentations. So it then to this cohort of committee members posed as a pressing concern. And of course, having appreciated based on our observations, and of course our observations would not have been as conclusive because we would not have relied on any scientific, data and so on. But we sought to disquisition the overall scope of mental health challenges in our province. And I think we sought to examine what the prevalence is, and of course, even the incidence to that effect. And what we would have detected through several, research studies, literature that is out there. And I'm happy that a number of the stakeholders who are here will have also contributed to that data, is that when we looked into a number of them, and I'll talk about, 2 if not 3, that we referenced, Dr. Mugono, is that we saw a rise in the number of these presentations. And of course, there's different categorizations. All of you would appreciate that. Then we looked into the VEDS study, which reveals that the prevalence, lifetime prevalence of mental health care presentations stands at about 25.7%. And we thought, well, could this be factually accurate? And of course, it also does some quotient on a 12 months a cycle, which would obviously be a bit nominal compared, to the 25.7%. Then we looked into the South African stress and health examination as well, which picked it relatively at similar figures or computation as would have been the VEDS study, and placing it at around the 29%. And this is for Gauteng. And this is for the Gauteng reading. And we thought, well, these analytics are quite interesting. And we also journeyed into understanding what are global perspectives on a country reports. And so we looked into the annual mental state of the world report. And I think the report was released sometime in 2022. And it gave some worrying a trend that when there was an assessment undertaken amongst a number of sample countries, South Africa fared the lowest in using the kind of a computation matrix that they were using. And we scored a relative lower number of 46%. And so what it did, it projected South Africa as being amongst the lowest countries in respect of having greater or responsive mental health programs, or the scourge of mental health presentations. But of course, not so long ago, there was another study about a number of the student community just in Joburg. And the study reveals that an average of about 24% of the students could present with anxiety disorders or depression. And of course, there are reasons attributed to that. Others could be biological, others could be based on social determinants of health. So there's a range of reasons attributed to those findings. And it worried us as the portfolio committee, because in addition to all of these reports, we have also made observations on the ground where we have seen greater presentations in our facilities. Not so long ago, we went to Helen Joseph Hospital. And there has been a makeshift. I think one of the things that we must commend the department is that they've made, efforts to try to revamp, have a mental health units, functioning and so on. But of course, the pacing could be something that could still be visited because it's moving in a bit slow. But I think the department will speak to that when they do get an opportunity. And so the Helen Joseph Hospital has got a 72-hour waiting section. What do you call them? 72-hour units, isn't it? And what we observe there is that against what the facility could accommodate, there's a never rise of presentations, which signals a problem at other levels, whether they be district level or primary health care. You know, because ordinarily people would present themselves in those facilities. And we thought we need to come closer to understanding what are the causal factors. We also went to a number of other facilities, South Rand, a similar observation. You know, and of course, individual members would have also reported that when we went to George Mukari, you are finding that it's getting overpacked. The facility would not have been intended to have as much a catchment population of presentations. You know, and I think what further exacerbates that is what I would have stated, the social determinants of health. Either the living conditions of some of the persons who present themselves. In other instances, it could be caused by trauma or substance abuse. Of course, in other instances, it could be biological. So it ranges across the board. And when we probed as the committee, I think it became apparent to us that part of the problem that the health sector has got to contend with, it's the possibility, and I don't want to reason that much, and hence I'm characterizing it guidedly as the possibility of inadequacy of resourcing as it relates to this specific program. I know there was a report prepared by the National Department attempting to understand and diagnose what the problems were related to mental health. And I think it was largely informed. You will remember some time ago with the formulation of the National Development Plan, there was a situational analysis that was undertaken. So if you go to chapter 10 of the NDP, you will find that quite elaborately it speaks about the mental health situation in our country, and that would have heralded your mental health policy revisions as you currently have them. And COVID also exacerbated. But the biggest problem was a financing of the program. And what you will find, I'm not so sure what the situation could be now, but with previous readings, reports revealed that only 5% of the overall public health sector budget was attributed to mental health programs. And so what it does, it sort of retards the ability of the system to be greatly responsive, because you are unable to attract the right kind of skills, have the right kind of infrastructure, research, all of that. And of course, when you deal with mental health challenges, you also need to put in place surveillance systems. You must invest in research, And so we looked into all of these issues in aggregation and thought, well, how do these implicate the ability of the Department of Health in Gauteng to be greatly responsive? Because as all of you could imagine, Gauteng represents the residency of about 16 million people, nominally. But if you will, Gauteng also contends with an additional number of patients and presentations from outside of the province. So provinces such as Northwest, Limpopo, Mpumalanga, Free State. So all dry provinces from time to time would prefer to refer their patients to Gauteng. And so that places an additional burden in the ability of facilities in Gauteng to cope. And that is why you will see other people falling out of the system. So the question around the treatment gaps manifests itself from there. But of course, Gauteng is also unique because it has got peri-urban spaces as well. And it's easier for other people to be lost in the value chain of gaining access into the system, for them to either receive a treatment or the kind of a help that would be warranted. And so your peri-urban spaces, whether they be in the West Rand, in the Vaal area, Tshwane also has, because there's an expansion of Tshwane. So if you go to the eastern parts of Tshwane, Ekangala, formerly Mpumalanga, you will find that there are those challenges. And the situation hasn't really moved because of the model and the construct of some of our health facilities. Notwithstanding, there has been a deployment of a personnel across the board. We've interacted with the district health teams responsible for mental health. But that is not enough. And I'm sure not so long ago, you would have been aware that there was a moratorium in the health sector, I suppose in other sectors as well, which caused some significant reversal in the deployment of the necessary human capital to anchor the program. In a number of facilities, we know that you did not have a sufficiency of a psychiatrist, psychologists, social workers, occupational therapists. So we're aware of those realities. And so we thought it necessary that we disquisition what should be the remedy. So we have already diagnosed what the problem is. But of course, you are the pundits, you are the experts. There could be other blind spots unbeknownst to us. I know earlier on when we were introducing, we spoke about associations or bodies that are responsible for nutrition. So we are largely concerned about the overall deliverology system, and starting from prevention, diagnosis, treatment, a continuum of care, which may also include a rehabilitation. And so essentially what brings us here, the purpose of what brings us here, is to identify best the practices, is to hear from yourselves as stakeholders who are at the coal face of interacting or interfacing with the realities associated with the challenge of mental health in our province. And so we really want to hear from yourselves. I think this team would have visited a number of health facilities, specialized psychiatric hospitals, your 72-hour units, some tertiary, some district facilities, even clinics. We have done that work. And we have a report. I think in a short while from now, we're going to share with you some of the observations born out of this report. But ultimately, we want to hear from you, so that we push back. Yes, there are policies, and they are very instrumental policies. But policies on their own may not be sufficient to mitigate the greater manifestation of this problem. And so the question that reverberates in perpetuity amongst us and amongst those that are mostly afflicted is, how do we resolve? What kind of policy interventions should be prioritized? How do we strengthen the ability of the system to respond maximally? I'll tell you, I sit in another portfolio committee, and I'm about to conclude, the economic development. And there's a research study that suggests that mental health, and I'm sure you'll recall that there are interlinkages between mental health and other quadruple burden of diseases, whether they be non-communicable or communicable, it says it costs the government a lot more not to treat mental health patients than it would if it were treating them. And so the rise in the numbers of mental health presentations also affects the fiscus. So it has got dire economic implications. And it attributes a loss in earnings of those that at some point or the other present themselves with some kind of a mental health disorder. Attributes it economically to 62.1 billion. 62.1 billion in loss of earnings, because this could be young people who are healthy. You know, this could be young people who could have been inventive enough to come up with ideas, products that would have stimulated our economy. But they are lost in the system. And then it goes on, the report, I think it also gives some representations about perinatal revelations amongst the specific cohort, I think in a 12-month cycle. And it attributes it to be about 42 billion. You know. And we thought this is something worth examining, so that we don't only look at it parochially, believing that it only affects the health sector, but understand it for it's a greater manifestation in how it implicates the rest of a society. So we want to invite your participation to collectively make reflections with us as the Portfolio Committee of Health, because we want to transcend just the doing oversight and sharing our reports with the department. We also want that the department adapts some of your input, some of your contributions in its planning outlook, so that together we can join hands in pushing back. You will remember, not so long ago, I think Member Bloom would have been the catalyst of some narrations there. The Life AC Dimeni saga suggested that there may be a level of pervasiveness in how we are understanding the magnitude of the problem and how we should confront it. And so you are called into a compact so that we leave no stone unturned. We cover all blind spots in our response to this problem of mental health in our province. I think with that said, allow me to thank you still. And I propose that we immediately move on to the fourth item on our agenda. We'll just give you highlights, Dr. Mugonoto. So you are not going to read like you are in a classroom. You give highlights of issues, and then we want to maximize, I think, the contributions from the stakeholders. So thank you very much for that. Over to you.
Good morning. Nondu, are you flatting? Oh, yeah.
Can you all see the screens? Okay.
Thank you. Thank you, Chairperson, for a comprehensive background that led the committee to undertaking a focus intervention study. On the 28th and the 29th of August 2025, the committee embarked on conducting a focus intervention study at Vescopis Hospital, Tshwane Rehabilitation Hospital, and Sterkfontein was the last one on the 29th. And the last two facilities, the committee conducted the study on the 16th of September 2025, and it was Kalinen and Dr. George Mukhari hospitals. The purpose of conducting the FIS was to assess the effectiveness of mental health services provided for mental health care users. Methodology was that the chairperson in each and every facility explained as he explained to our colleagues, and there was an engagement between the committee and the management of particular facilities. And there were also walkabouts where the committee observed some of the incidents, type of patients that were admitted in those facilities. And particularly in one of the hospitals, I know in research, it's not yet a report, you're not supposed to mention, in one of the facilities, there were young men that you would think they should be either a tertiary hospital, a tertiary education or facility studying, or they should be working. However, you could see shame in the way they are affected by mental illness. The rationale thereof is that there has been an outcry globally in literature and physically in our communities that mental health is increasing, particularly in Gauteng, because we live in Gauteng. We see most of children suffering from mental illness. And based on that, the committee is not the community. The committee was not certain about types of mental illnesses, causes of mental illnesses, factors enhancing or impeding access to types of mental health service providers. Findings, I consolidated the findings. Number one, the committee found that the type of rehabilitation offered in the Tshwane Rehabilitation Hospital was mostly for physical function restoration rather than mental restoration. Therefore, the findings that are reported here are for the remaining 4. It was found that there's aging infrastructure leading to frequent equipment breakdowns exacerbated by proximity to mining operations, resulting in high maintenance costs. This hospital is situated in the proximity of a mining company. And then also there was limited operational resources, including aging laundry and other essential equipment, which hampers efficiency and service quality. There was high number of patient safety incidents, PSI, which is one of the indicators that the department is reporting quarterly to the committee. The particular facility indicated risks to both patients and staff, whereby sometimes they find patients who have drowned while trying to have a bath, and some of them attack either staff members or attack their peers. And we know of the arson that happened in Dr. George Mukari, though we don't know what the cause was. But they also mentioned that sometimes because there's smoke, and in the hospital we know that oxygen and smoking are not compatible. In conclusion, based on these findings, the committee noted with concern the following. Most of the mental health care users were young men and women addicted to substance abuse. Because when the committee...
so that they also, give highlights. I'm not so sure whether we're ready for that. There's a presentation, isn't it? Okay. Maybe let's hand over to the department to take us through. And then immediately after that, we'll proceed to opening the floor. Is it a presentation? Maybe, are you flagging it? Or you'll talk to it from there?
She has already introduced herself.
Good morning once more. I'm asking to stand, Chair, if that is fine.
It's okay.
Okay. Thank you so much for the research presentation, and would like to say we also believe in evidence-based practice. So I believe some of the focus point will come out of this presentation as well. So we just have a little bit of introduction. I'll try to be quick. I won't read line by line. So indeed, we would like to agree with the chairperson that mental health is a growing communicable disease, and that is actually aggravated by the COVID-19 pandemic, as well as the state of the economy currently, and the substance abuse issues, as well as social determinants. So we would like to say mental health is also guided by the pieces of legislations which will be touched in this presentation as well. Then mental health services are also in line with the national, international, national, provincial mandate objectives, as well as fundamental provisions of the Mental Health Care Act. Let me have the next slide. Okay, like I've already indicated that we are guided by the Mental Health Care Act, which is our top legislation there. Then we also have National Mental Health Policy Framework, which is also guiding the implementation of the mental health services. Let me get the next slide. There are also the pieces of legislations that are also guiding the mental health practices. We have Criminal Procedure Act, the National Drug Master Plan, the Health Sector Drug Master Plan, and we also have the acts that relate to vulnerable persons like your children, women, disability and substance abuse. So we are also in line with the NHI, and the department has brought mental health care to the fore and is implementing effective evidence-based solution to bridge the gap as well. Okay, let's have the next slide. So now within the Mental Health Care Act, there are provisions there, and of which number one, it emphasizes on the integration of the provision of mental health care services into general service environment. So mental health services are integrated with the general health services and are part of the primary health care services package currently. So generalist professionals at the PSC are also supported and capacitated by the specialist mental health professionals. So one of the provisions in the Act is also to coordinate access to the mental health care treatment rehabilitation services. And we can confirm that in Gauteng we currently have 99 community health clinics and larger PHC clinics that provide community specialist psychiatric services. So strengthened with MDT in the district level. Then under Section 34, we have 72-hour assessment, which must be done near as possible to the patient's home. And in Gauteng, we have 26 general hospitals that are listed for 72 hours assessment. The next slide. Okay, so within Section 5 in the Mental Health Care Act as well, there should be designation of health establishment. So in Gauteng, we have 11 general hospital wards that are designated as psychiatric hospitals. We also have 3 specialized psychiatric hospitals designated as well to provide mental health services. Then within the 3, we have 2 that are providing the forensic psychiatric services. We also have 1 designated care and rehabilitation center. So, and we also have private hospitals as well that are licensed in terms of the Mental Health Care Act to provide mental health services as well as ECT services. Then we also we are prioritizing the promotion of community-based services in our mental health services. So currently we have about 138 residential and daycare mental health licensed NGOs with approximately 5,300 beds. So they are also licensed in terms of the Regulation 43 of the Mental Health Care Act, and monitoring support is provided to them. So we also have a mental health review board in all the district of Gauteng. Okay, let me have the next slide. So this is just a breakdown of the general hospitals that are in Gauteng, that are designated as psychiatric hospitals. In Johannesburg district, we have Chris Hani Bara Academic Hospital, Helen Joseph, Charlotte Matkeke. Western, we have Leratong, Sidibeng Kopanong, Ikuruleni Telemorani, and Tembisa. Tshwane will have Dr. George Mokari, Steve Biko Academic Hospital, Mamelodi, and Kalafong. Okay, I'm trying to be as quick as I can. So these are the specialized hospitals in Gauteng, as I've already stated, that are designated for specialized psychiatric services. Then these are the beds, number of beds per hospitals. Then these are the active beds, of which Vescopis is around 778, the active bed currently. Then Sterkfontein 521, Tarau being 137, and Kalinen being 165. So these are beds that are usable. Some are not active, of course, due to continuous progress when it comes to infrastructure. Okay, let me have the next slide. So this is just showing a pyramid to say, when it comes to mental health services, when you look at the pyramid, down there we are having informal community care and self-care, which is where we are expecting a lot of users to be there. Then in the middle, we'll have the psychiatric services at the hospitals, on top being specialized hospitals. So the expectation is that most of the users should be managed at a community-based level, and we don't have to have many at the long-term one. Okay. Let me have the next slide. So mental health service also emphasis on the health promotion and the illness prevention, so that there's early detection and management of basic conditions. We also prioritize screening so that for mental health and substance abuse in order to detect the condition early. We also have inpatient and outpatient services for acute and chronic mental health services. So 2 service providers are contracted in Gauteng so that they can also assist when it comes to provision of the long-term care. And currently we have 2 contracted care, of which we are having about, is contracted for 1,930 chronic mental health users. So yeah, I think that is that. Let me have the next slide. So we also have forensic services, which is in line with the Mental Health Care Act 17 of 2002, Chapter 5, where there are observations and state patients, and we are also guided by the Criminal Procedure Act, and assessment for proof of criminal capacity for children who are 12 and older, but under 14 years in terms of Section 11 of the Child Justice Act. Then assessment of victims of crime in terms of Sexual Offense Act 37 of 2007. So currently services in Gauteng also go, they are also accommodating Mpumalanga, Limpopo, and Northwest. I think that was mentioned by the chairperson as well, that is also contributed to the burden of the service that should be given to Gauteng. So we have other provinces that need to be catered for as well. Okay, let's have the next slide. So now children with, we also have specialized programs where the focus will be on children with severe disruptive behavior. Then there's provision of in- and outpatient services. There's management of referrals from the community, Department of Education, School, Department of Social Development, child, youth, and care centers. So services extend to parents and other affected family members as well, providing the capacity building program to officials at school for autism. That is also done within the mental health service. There is training that is planned for staff at CYCCs and other centers as well. Okay, let's continue. The next slide. So under specialized program, we also have from the Department of Health, the program of substance abuse will require the MDT. So each GPG department and civil society have their own mandate as outlined in the National Drug Master Plan. So how the Department of Health is also fulfilling, their mandate as well in terms of the National Drug Master Plan. I think that is that around substance abuse. Let's proceed. Okay, so now this is about the budget, because one of the concerns that was raised is around the budget issue. So in accordance with the aims and objectives of the National Mental Health Policy, which is guiding mental health services, Department of Health has budgeted for the following services. So within the Mental Health Directorate, there is budget as well for COE, goods and services for the Directorate and the Secretariat to the Mental Health Review Board. As I've already stated, that we have Mental Health Review Board in all 5 districts of Gauteng. Then we also have contracted care centers, which is Life in Ganyisa and Clinics Health Group, and that is budgeted for as well. Then we have mental health, residential and daycare, NGOs. We also have a ring fence budget for that program as well. Then specialized psychiatric hospital have their own budget too. Clinic and specialized district mental health services, there is budget for mental health service, and mental health wards in general hospitals are integrated in the hospital budget too. So we'll explore on this in the next slide. So this is just the numbers when it comes to the licensed mental health NGOs. In Gauteng, we have about 138, and this is breakdown of the type of the services that they are offering, as well as the category of the mental health care users that they're giving service to. So I believe this is the number. We have the total of 138, and they are broken down in the numbers there. So this is in Gauteng. Okay, let me have the next slide. Then we have, as I've already indicated, that the department has contracted with Life in Ganyisa, Banning and Waverley. These are the numbers of beds that are contracted for. Like I said, in total, they are 1,930. So there they are broken down per hospital. Okay, let's have. So in terms of infrastructure, yes, it was raised as an issue in the research as well. So department has prioritized an elevated mental health service to ensure compliance to the legislative policy and address the growing demand. So currently there's an ongoing refurbishment and renovation of the wards in identified hospitals to address the severe shortage of mental health beds in the province and to provide a conducive environment to manage mental health cases in general hospitals. So the following hospital had their ward refurbished and renovated in the year 2019 to 2015. So we have 17 hospitals: Gauteng, Helen Joseph, Jubilee, Charlotte Matkeke, Southland, Tambo Memorial, Mamelodi Pulusong, Chris Hani, Edenvale, Tembisa, and Betatoa. So there have been some renovations that were done in this hospital from the year 2019 to 2025. Then in the year 2025, 2026, is Southland, Tshwane District, Far East Rand, and Benki Mulangeni. So those are renovations and refurbishments that are taking place in the identified hospitals. Okay, let me have the next slide. So there was refurbishment of the female ward post-fire incident at Dr. George Makaro Hospital, and further renovations are planned for the year 2026-2027. So the forensic observation ward and Sterkfontein Hospital is planned for 2026-2027. So there was renovation work that were done for phase 1. So it's still work in progress. So Sebokeng Hospital has submitted a business case for the mental health unit, which is completed and approved in collaboration with the National Department of Health. Okay. So we'd like to confirm that Department of Health has invested more on human resource in 2021 in order to address the recommendation that came in Omba's report. So the request was made to Treasury, and budget of 500 million was approved. So 350 million was allocated in order to strengthen the human resource component at the 8 hospitals as well as 5 districts. So this allocation was used to appoint approximately 476 additional multidisciplinary mental health professionals, administrative clerks, security personnel at the 8 hospitals in order to increase their beds, and as well as the 5 districts. So there have been a new appointment of the MDT as well as the teams. So the remaining 150 million was allocated for the contracted care services that provide long-term care to chronic mental health care users. Okay, let me go to the next slide. So there is improved access to mental health service, mental health professionals in the primary healthcare service through appointment of 476 MDT. So appointed, there are 5 specialist teams that are appointed in each district of Gauteng, and within the team we are having psychologists, psychiatrists, psychiatric nurse, which one am I leaving out? So the full MDT for 5 districts were appointed as well in order to strengthen the district clinical community psychiatric teams as well. So they've appointed additional mental health care professionals at the psychiatric clinics. So improved support and monitoring to mental health NGOs have been implemented as well. So currently we do have teams that are appointed in each district to also support and provide professional interventions to the mental health NGOs. So I think that this MDT mental health professionals are appointed across the district, and we have psychiatrists, medical officers, nurses, psychologists, social workers, occupational therapists, EHP, as well as dietitian. So these are the teams that are supporting our mental health NGOs life as a minimum. So mental health benefit from the grant. There's also grant that is received from the National Department of Health in order to strengthen mental health services and increase access to the mental health professional at PSC. So to reduce the backlog of forensic observations at the 2 specialized psychiatric hospitals designated for forensic psychiatry, Sterkfontein and Vescopis, they've been appointment of professionals through NHI grant. So allocation for 2025-2026 were approximately at 43 million, and 82 professionals are contracted currently in order to assist with the mental health services. We have psychiatrists, psychologists, social workers, OTs, and registered counselors, as well as medical officers with diploma in psychiatry in order to relieve the burden and provide mental health services. Okay, let's proceed. So as it was indicated in the research, yes, there are challenges that we will highlight them here. So it will be under the item acute mental health services. So there is high demand and overcrowding of the emergency departments at the hospitals. So that has been noted as a challenge as well. So in order to mitigate that, or the intervention, we prioritize refurbishment of the identified general hospital ward in order to create conducive environment for mental health care users and those undergoing investigation during 72-hour assessment. So there's also a process that we put in place when it comes to contracted care. Their beds has been expanded, so they have a lot of vacancies currently. So we are in a process where we are decongesting the acute wards through the transfer of the patients that are stable from the hospitals to our contracted care centers. So that process is an ongoing process. We are meeting with contracted care every Fridays and the hospitals so that patients can be transferred to the contracted care. Then the issues around shortage of psychiatric trained nurses, it was mentioned in the research as well. Indeed, there is that shortage, and that has been affected by the current curriculum. However, we have escalated that to the training institutions. They are working on the accreditation for them to be able to provide those training. So within the department, there is training of generalist doctors and nurses on mental health module, which is taking place. And furthermore, we are also collaborating with human resource development in order to roll out that program. So the challenge around PSI, it was also noted in the research as well. So we are collaborating with the Sterkfontein Hospital, currently providing training to 100 officials in this financial year on the management of aggressive patients and calming and restraining, so that we can reduce the PSIs. Okay, let me have the next slide. Okay, the other challenges around the impact of additional HR is affected by the space constraint at the clinics. So yes, we are at the clinics, there are issues around the space. In as much as we have many human resources now, the challenge is that there is a problem of space within the clinics and insufficient consultation rooms as well, which is compromising our confidentiality. So the intervention is that we requested.
I want us to speak quickly through them because we must manage time.
Yes, okay. I think I'm about to finish. There's already a few slides. So it's the issue of space, of which the recommendation was around mobile clinics as well as the park homes, which is pending budget availability. Then the backlog of forensic patients, which is also addressed by the additional staff from the NHI grant. Okay, let's see the next slide. I think I'm about to finish. Okay, I'm done, Chairperson. Thank you so much.
All right. Thank you very much. And that was quite comprehensive.
Sorry,
but
Chair.
I think it does help in a way. I don't want to waste time. I'm told that the MEC is she outside? Or what do we know?
Peter is going to check outside, Chair.
Okay. So maybe whilst we are waiting for the MEC, we had requested our stakeholders, those that were interested, to share with us maybe a paper or any other presentations to do that. But we had set a time frame for that. And I think only one had showed an interest, which is the Freedom Recovery Center, and I think represented here by Mr. Stalls. So whilst we are waiting for the MEC, and we'll revert once the MEC comes in, so that she also makes her own remarks. But I suggest at this point, we invite Mr. Stalls to also quickly navigate us through his presentations, so that we become all the wiser. The report by the department, over and above Dr. Slebe, might suggest that the challenges are not as major. That's the reading from the report. But I suppose we'll want to hear frankly from the stakeholders what their observations are, including that of the committee. But maybe let's not respond to that now. We'll still come back. So over to you, Mr. Stalls.
Honourable Chairperson, thank you very much. Honourable Committee, thank you very much for the opportunity. Just some background. Freedom Recovery Centre provides rehabilitation services to 102 people. That's inpatient care, of which 30 beds are medical aided beds. The rest are subsidised beds by the Department of Social Development. In addition, we supply 42 subsidised half-house beds for secondary care. May I have the next slide, please? Gauteng carries the burden of the national drug problem. Of 7,244 people who presented themselves for rehab in the second half of 2024, the bulk of them sat in Gauteng, of 3,199. After marijuana, the percentage as a first choice drug was 38%, and alcohol, the biggest problem we had was crystal meth or methamphetamine. Now, it's important to note here that all three of these substances are regarded as contributors to mental health issues. And then also the Medical Research Council indicated that the number of people who presented with dual diagnosis when they were admitted increased with 5% from the previous period to 20%. We noticed that the trend shifted away from the opioids when COVID started, and we sit in a situation now where mainly most of the people that get admitted to our rehab center arrive there already in psychosis. May I have the next slide, please? I just gave you a graph there to indicate what the situation looks like. The top line is Gauteng, and the bottom three lines is the rest of Gauteng. The numbers seems to be on the decrease. However, I wouldn't trust the numbers for the second period of 2024 due to the funding issue that was prevalent in Gauteng in 2024. I think there was a number of admissions that couldn't take place because of the funding issue. May I please have the next slide? So the challenges that we identified in our work is that there's an overspending of budget on substance abuse prevention and awareness, and not enough budget being actually channeled through to the treatment. And there's not enough focus at this point in time on mental health and psychosis as a result of substance abuse. Secondly, aftercare is underperforming. Aftercare is underperforming in Gauteng as a result that there is no decent aftercare. As a result of the stigmatization around drug abuse, the moment that institutions hear that somebody was involved with drug abuse, they're not really interested in giving aftercare. So our substance use lines with mental health issues struggle a bit. Then 70% of all subsidized rehabs in Gauteng do not attend to mental health issues because they are not equipped or capacitated enough for the treatment of mental health issues. May I please have the next slide? There is a shortage of psychiatric help and medication. There is not enough network between the substance use disorder rehabs and the Department of Health clinics. Waiting periods are sometimes very long before we can see a psychiatrist, and so forth. There's also poor information or wrong information that is spread in our townships or by leaders or spiritual leaders. For many of them, mental health is still a very foreign language. They do not buy into something that could be associated with mental health. Limited access to care for substance abuse treatment. We've got a severe shortage in Gauteng. I speak under correction, but one of the figures that I heard was that we are short 2,000 beds per month to address the substance abuse problem. And then insufficient staffing and training for healthcare professionals. We need to amp up on that. May I please have the next slide? Thank you. There's also fragmented integration of substance abuse services into primary care. We very often find that a person first gets treated for his psychiatric disorder and then they go for rehabilitation. It is actually preferable that the two take place concurrently. Then the cost of mental health healthcare practitioners makes it impossible for treatment centers to employ their own psychiatrists. In one instance, I phoned for an appointment for a medical aided psychiatrist, and the waiting time was 2 months before we could get an appointment with that psychiatrist. And the problem there is, unfortunately, in substance use disorder, the field that we work in, psychosis and breakdowns do not keep office hours. They cannot wait 2 months before they can get help. May I please have the next slide? The opportunities that we have is that we need to strengthen abuse, or we can strengthen substance abuse prevention and treatment programs by partnering with other NGOs and government departments like the Department of Health, Department of DSD, of Social Development and so forth. We also need to improve access to medication-assisted treatment, MAT and psychosocial interventions. We very often find with our centers, we find that we do not always get medication from the clinics, or people arrive without medication. Rural communities about how substance abuse works specifically, and what the mental health conditions are that is caused by substance abuse. We also need to foster improved collaboration between different government departments, NGOs and community organizations. May I have the next slide, please? A recommendation, we need to increase funding for substance abuse. I speak for our own center. We've been operating on the same budget for 3 years with the funding that we've been getting from the Department of Social Development. That needs to be relooked. We also need to allocate a specific budget for substance abuse services accompanied with dual diagnosis. It takes more resources to treat a person with mental health issues accompanied with substance use disorder. Then we also need to integrate services. We must try and avoid where we first treat the one and then the other. The two must be treated concurrently. Next slide, please. We also need to train our healthcare professionals. We find that there's a big lack of knowledge amongst nurses about how substance use disorder works, etc. We need to increase the number of community-based services, but you've touched on that as well already. So I'm glad to see that I'm not the only one that's missing that. And then targeted interventions. We need to develop targeted interventions. Our biggest problems in Gauteng is the use of marijuana, the use of alcohol, and the use of crystal meth. We need to strategize interventions with that. We also need to strategize interventions with educating our communities about mental health and substance use disorder issues. May I please have your next slide? Mental health support. We need to strengthen mental health support services, including early intervention and treatment for psychosis and schizophrenia. We must deliver integrated services. I've touched on that already. I'm sorry for the duplication. Capacity building. We need to build capacity for healthcare professionals to manage specifically crystal meth use and related mental health issues. Just as an example, my registered nurse that's with me, she was attacked by one of our service users on Saturday. And he came in because he was binging on crystal meth. So we need to find ways and solutions around that. Then community outreaches. We need to expand community outreach and aware programs to address stigma. There's still a huge stigmatization around drug addiction, especially in our townships and our rural community. Getting the buy-in from the parents of victims of substance use disorder in those areas is sometimes very problematic. And then we must have a data-driven approach. We must do research, we must keep track. I think I've heard somewhere that the Department of Health wants to develop a system where with my ID number, I can go to any clinic and get access to my medication. We need to expand that system so that we can also keep track of where people get treatment, what treatment they got, etc., so that we can fine-tune our services that we deliver. Please may I have the last slide? Oh, sorry, second last slide. Family support. We need to get families to buy into the treatment of their loved ones. Very often we find that when a person with, for instance, schizophrenia and a SUD problem gets dropped at our rehab, and then the families don't want that person. They're not ready to accept that person out, and we struggle to find aftercare services for them. May I have the last slide now, please? Just some implementation strategies that we thought of. We need to develop a comprehensive substance abuse strategy aligned with mental health care. The Mental Health Care Act, the National Mental Health Policy Framework, and the Prevention and Treatment of Substance Abuse Act. I know that this, the last act has got the CDA, but I think we need to pull resources wider so that we can address the problem more efficiently. Then we need to establish a task team, a combined task team that overlooks and oversees substance abuse service delivery and monitor progress. We need to collaborate with NGOs and community organizations to leverage resources and expertise. And lastly, we need to develop a monitoring and evaluation framework so that we can track progress. I thank you very much for your time.
Thank you so much, Mr. Stolz. I truly appreciate the presentation. I wish the other stakeholders were also sharing with us their own observations, but also making recommendations as you would have. And I think we're firmly in agreement with your presentations, including those insights, because what further compounds the mental health burden, particularly in our province, which is overly concentrated, is the burgeoning abuse of substance abuse, and it bears a correlation to a number of other risk factors. So alcohol abuse, drug abuse are also risk factors, and so they sort of exacerbate the situation. I'll tell you one other thing that the department might want to intensify, MEC, is the area around screenings for substance abuse, because we often tend to take it for granted, and with the overloaded healthcare workers, they might not fully appreciate, because they may also not have other traits. There's what we call, I learned some time ago, there's a certain specialty called addictionologists. So these are people who are responsible for knowing how to manage presentations of a patient with substance abuses, And so the treatment, the protocols, of course, you will have those as part of the guidelines, but just on this specific thing, because there are areas where we're seeing a greater prevalence, which might require, uniquely designed programs, including what you have stated there, part of awareness. So intensifying on awareness is also quite important. But let me not labor that. I think at this point, allow me to welcome the MEC of Health, Me Nomantu. I see in the program they wrote Nobantu. So it means it's in a plural. It's in plural. Nobantu. But it's actually Nomantu Ngomoralo, the MEC of Health in Gauteng. Very passionate, very energetic. We hope your MEC, you will also collectively reflect with us to come up with the right kind of a solution to the burden of mental health. But we know that you have been running around, you have introduced a number of programs, and we are hoping that you will engage the stakeholders here so that they gain a greater insights into your thought processing to mitigate the manifestation of this problem. So thank you very much. Can we give a round of applause? Shine. Let's just say shine. Yeah. So thank you very much. I earlier checked with the MEC whether she might want to make her remarks now, but she has requested that she does that as part of the responses. So we're going to move swiftly. I think we're still in schedule, although a bit delayed, 15 minutes. So at this point, we really want to open up to you. We did say earlier on when we opened up that we want to hear from yourselves. Much has been said, observations would have been presented, but ultimately there's no completion without hearing from yourselves. We want to hear as a practitioners, as researchers, those that are in our academic institutions, our NGOs, our own communities that are here. We want to hear from yourselves. I know members had also wanted to come in, but I said they will come in after you. So the luminaries of the day are yourselves. Your voice carries more weight than those of the members themselves. The members will come in a lot. So I want to do it in an orderly fashion so that we can structure our engagements thoroughly. Are there any stakeholders that might want to present themselves on all of these issues so that we take up your hands, we record? Is there anybody? And then we'll just maybe give you numbers, isn't it? I'll just give you numbers. I'll start with the madam on my left. We'll accord you a number one. You're going to be number one. And then the lady there, the beautiful seraphic lady there, number 2. The madam on the middle table, it will be number 3. Yes, ma'am, you. Behind the yes, you are going to be number 3. And madam, you will be number 4. Mama will be number 5. Let me stand up so that I can see. Mama will be number 5. Are there any hands at the side? Say you will be number 6. Madam, you will be number 7. I take it this would be our first round. Is there any other one? Any other hand? So you will be number 8. I think let's memorize those numbers, isn't it? So we only have 8 hands. You can speak in any language. So those who are from our communities, don't think that you are forced to express yourself in English. So in any language that you feel comfortable with, I think we're open to that. I don't want to leave out anybody. Do we have 9 and 10? Tell us your observations. Where do you think the department might have to strengthen areas requiring improvement or any other thing that you think may be a policy blind spot and you might want that the department fashions itself to it? Is there anything? Madam, you will be number 9. I'm encouraged. I see there's a lot of women interest. And that's because mental health actually affects more women than men. You know, studies reveal that really. So Mama will be our number 10. Yes. So thank you very much for that. I agree with women are mostly affected, especially and vocal again. And postnatal, we see a lot of presentations of women coming into our facilities, even readmissions. So there is that kind of a problem. So let's start with our number 1 there. You introduce yourself, you tell us your name. If you are coming from any organization, also state the name of the organization. Thank you very much. Can we agree? I know we want to give you ample time. How much time is enough? Can we agree? So that we also govern our meeting. Is 3 minutes okay? 2 minutes? 5? Okay. Let me believe that you will be disciplined enough to manage yourself, isn't it? So that I don't curtail anybody. Thank you very much, and over to you, ma'am.
Thank you very much. Is it 5 minutes? Thank you. Honorable MEC, members of the committee, chairperson, and fellow committee or community members, I am Bharti Patel. I am from the South African Federation for Mental Health. It is a national non-governmental organization. And we have 17 organizations, which are NGOs, in all 9 provinces. For Gauteng, we have 4 organizations, and I have Moses Mashlangu, who is from Northern Gauteng Mental Health. I think it's important to note that I really appreciate the presentations made. Mental health is not just a health issue. It is a human rights issue because it's a responsibility of all of government, not just the Department of Health. When a person lives in a community and there are stresses like the social determinants of health, we have so many issues in communities. We have substance use disorders, we have GBV, we have violence. All these lead to mental health issues. And if we look at that pyramid that was shared by Dr. Lekhwadi, you look at the bottom of that pyramid, and that's where self-care takes place. So communities that are more prone to violence, GBV, substance abuse, they need a targeted approach. So I assume, and I know, that Gauteng is broken up into districts. Do we have statistics from different districts that guide intervention? Which are the most vulnerable communities or districts, and how is the budget then allocated to those districts, targeting the most vulnerable, right? And then we look at across the life stage, from birth to old age. How do we target mental health specifically in those communities? There are schools in those districts that need targeted intervention. So my suggestion would be to start looking at Gauteng, break it down into districts, and then start looking at an all of government. We need health, we need social development, we need SAPs, we need all of government to come to the party and say how much of their budget would go to that, to mental health in that district. I hear a lot about figures. We talk about challenges and allocation of budget since life is Dimeni. What I'm not hearing, what achievements are we proud of? What have we achieved so far with all these budget allocations? Did we achieve something? How many problems have been resolved? Because we are throwing money at problems and we are reactive. We are building hospitals, we're building beds, increasing all these resources. But what are we achieving with that? What is very sad for me is that NGOs have been targeted as being illegal since life Esidimeni, and their budgets have reduced to the extent that an organization functions on 30% of what it actually takes to care for people in the community. The responsibility of NGOs now becomes, we've got to raise money and we've got to knock on doors just to keep people out of hospital. Because that's what NGOs do. What they do is self-care, community care, relapse and go back into the hospital. At one stage, we heard it costs us over 25,000 to look after one person in a tertiary hospital. And an NGO is given less than 2,000. What is it per individual? 2.7. Just to look after a person in a community. That person is going to relapse and then it's going to cost us 25,000. So we should start targeting or allocating that budget. The best scenario I've heard is that, and it's in the mental health policy and our Mental Health Care Act, that when a person is discharged from hospital, that budget must follow the person into the community so that the person can recover fully. And that is my plea. So I do have a lot, and we will make a presentation. I'm hoping this is not the last interaction and collaboration. And we would like to be invited to the table when we are planning budgets and when we meet as all of government, because stakeholders like NGOs are very keen to participate. Thank you.
We couldn't agree more with you. So I think we'll have to reflect ourselves on a secondary leg of these engagements. Can we take our number 2?
Good morning, MEC, Chairperson, and everyone in the room. I'm Dr. Nomfundo Nhlapo. I am a consultant in the opioid substitution therapy program across Gauteng through the Global Fund and CDC projects, taking care of patients in the Tshwane, Sedibeng, West Rand, Ekurhuleni, as well as City of Johannesburg. Numbers equating to above 2,000 patients on OST. I'm also part of the Gauteng Health Task Team. I'll just identify some of the challenges and also make recommendations shortly. First of all, I think one of the challenges we do have is just identifying the custodian of substance abuse. We often stuck between DSD, Department of Health, and where there's overlap, we never get to make much progress because we just have a tennis ball that's passed from one side to the next. So recommendation is better collaboration between the two departments, first and foremost, greater involvement to Department of Health partners like ourselves in terms of managing substance use. The other is that the focus on substance use does seem to be quite dampened down when we speak of mental health. If you look at some of the presentations that have been made, it seems to be such a secondary, yet it's a primary cause of our mental health problems. And I think just taking away the cloud of denial will help us to really get much further. The last speaker who presented spoke about the shortage of beds in Gauteng alone of about 2,000, I believe. Well, we have very much successfully piloted the outpatient model. And unless we move towards it, we will not fight this enough. All the programs I'm telling you about are outpatient models with high success rate, greater retention, and decreased number of relapses, and in addition, a higher percentage of reintegration as well as family reunification has actually been showcased through statistics that we are willing to also share with you. These outpatient programs have largely been run by donor funding, and we have had a severe cut of that, an obvious crisis that we all know about. And so it is really time to start seeing a greater and faster move to opioid substitution therapy being taken up by the department quite more seriously. In addition to that, an immediate move to skills transfer between the existing or the NGOs that are left, so that when funding is pulled out, we don't start finding ourselves in a crisis, which ends up leaving our patients quite challenged. We're dealing right now with a Tshwane issue where we can no longer initiate patients on OST, and now there's actually no plan of what might happen to those patients and how we can sustain the program going forward. Over and above that, I think we have a big challenge in the referral system. When you are facing a patient who does need psychiatric intervention, just yesterday I spent the whole day without any joy trying to certify a patient, because our policies talk about people who have family members who can actually facilitate in that. My patients live on the street, so how can I actually get them certified when I know they are a danger to the community? We also have a sort of denialist, if you allow me to say so, on the concept of harm reduction. I know we've made headway recently on the fact that our patients are not now being arrested because they are found with sharps on them because of the harm reduction program. But over and above that, let us understand that there's an infectious disease transfer that happens as part of substance use that is related to injecting. We have a pandemic called hepatitis C. I'll just share a study we did in the city of Johannesburg, which entailed 1,500 patients who are on the streets, who are injecting. Out of those patients, we're piloting a hepatitis C self-test study, and we found that 89% of them have got active hepatitis C, not previously infected, currently infected. That becomes the infectious pool that can transfer this condition further. And in a country where liver transplants are a luxury, we have to be more active in preventing that transfer of hepatitis C, especially because to manage one patient does not cost any less than 35,000 right now. Thank you.
All right, thank you very much, ma'am. Can we take our number 3?
Good morning still, all protocols observed, and thank you again just for the opportunity and being invited. It's an important opportunity for us to come together and to talk about it. So my name is Cassie Chambers. I'm the Operations Director at the South African Depression and Anxiety Group. And just to echo what my colleague Barty has also said, we would also love to have the opportunity to engage with the Portfolio Committee again in a formal presentation and provide information. Unfortunately, we just had notification yesterday. I think what's so important about today and having the data and the report is that with more information, knowledge is power. And now the real question is, what are we going to do with this data? Where to from here? I think from our real recommendation is to have a real clear outcome on the next steps of how do we use this information so to make sure that we are more engaged and more involved going forward. I think I have a few questions with regards to some of the presentations. We had listed some of the renovations that had happened at some of the hospitals, but those that were investigated, specifically Cullinan and Westkoppies, were not part of the renovation plans that have happened or going forward. And we just wanted to know, with the highlights of the report today from the Portfolio Committee, are we going to include some of those renovation plans in the next few years as well? My next question is with regards to the HR. I know that there's an increased budget for HR since 2021, and there were 476 additional placements, which is very encouraging, especially because we have 3,000 calls a day from people who are struggling to access care and treatment, not just in Gauteng, across the country, but the majority of our calls are coming from Gauteng. My question, has all those placements been filled to date? And would there be a breakdown? My other concern, wearing our mental health advocacy hat, and a disclaimer, we get no funding from any Department of Health, so we're self-funded, is the patient safety incidents. I think it's really concerning when we're sitting here thinking a patient drowning in a bath. And when we've had and been part of that tragic history of life Esidimeni, that is a big concern. And again, echoing what Barty said, it's a human rights issue. Do we have a breakdown of those PSIs across those 4 hospitals that were reviewed? Do we know what types of issues, the number, how many happened at each hospital? I think that would give us insight into where our key focus and urgency should lie. I know we've discussed on some of the training that's been in place, but another question with regards to increased security for PSI to reduce that, and not just looking at helping aggressive patients, but also what are some of the other safety issues that come with drowning, which is not from an aggressive patient. So that would be my other query. Another question is this report and this investigation being discussed or presented to mental health review boards? And I'm not sure if there are any mental health review board representatives in the room, because I think it's also important that these are findings from hospitals within their districts. And I think that the mental health review boards would also be able to give us data that could actually help with some of the information that's missing. I think one of the things that I would like to see as an NGO is that many years ago there was a multi-sectorial mental health task team for Gauteng, and there were meetings and we were involved in that. And unfortunately we've fallen away with those meetings. And I think it's opportunities like this where you bring in different stakeholders and you're sharing insights. So that would be one of my recommendations, is to have more of those regular meetings, because as stakeholders we do want to engage, we do want to share and support. We need those opportunities to be in the same spaces and around the same tables. I would like to ask that we adopt a clear set of recommendations with this report, so that we're also able to be part of that process of change and that we can actually monitor and track it. I think, as I'm ending this, is that it's really important to bring that lived experience, and as an advocacy group we're representing so many family members. As just last week I have a mother whose 33-year-old son has been told he's got mental brain issues and he can't work. He's been locked up at home, and she's desperate to get him somewhere to go and to do. And I think it's through sharing this kind of information and hearing these reports, we have to do better. And I think we can only do that together. Thank you.
Thank you so much, Madam Chambers. Can we take our number 4?
Good morning, everyone. I'd also like to acknowledge the protocol in the room. I would like to introduce myself, Nomsa Masoka. I'm a mother of an autistic child. My son is 21 years old. He's been diagnosed with autism from the age of 3. As a mother raising a child with autism, it's a very difficult condition if you all know what autism is. But the challenge that we have is the communication between departments. There's a high increase in number of children being diagnosed with autism, which actually increases the burden to the Department of Health with regards to medication. There is no database that we have with these children once they've been diagnosed and followed up through to Department of Education. Somewhere along the line, we miss these children and they are not followed up, and these are the children that ends up at home with parents not knowing what to do with regards to the management of their condition, as it's very difficult. And we also have situations where the schools also refuse to take our children because the schools are not well equipped. I so happened to be at the Eastern Cape Department of Education, Inclusive Indaba, yesterday, where they were discussing how they're going to accommodate learners with severe to profound intellectual disability, because the classroom setup is not well equipped to deal with our children's complex issues, which is sensory, behavior, and many other issues that our children presents with. Now, I'm sitting here as a mom of a 21-year-old son who is out of school, and I also am a young mom who still has to pursue her own career. I cannot be able to keep my son at home because the caregivers also will not be able to cope to care for my son. And my life still has to go on. So now there's a burden that is put on caregivers. The mothers of children with autism and parents are suffering from what is called caregiver syndrome, fatigue syndrome. So there's two mental health issues that we are now facing, that of the parents and that of children. And I'm not sure how many facilities we have out there that are well equipped to deal with autism. I have once taken my son to a facility where he was drugged, came back looking like a zombie, was actually bumping walls everywhere, because people think to be able to manage our children, you are supposed to put them on medication. But with the right kind of environment and stimulation, you could still be able to have our children thriving in an environment that understands them. So there is poor communication with regards to the care and the management of children with autism. I'm a mom now sitting at the position where I decided to quit my job. I had taken all my savings, tried to open up a center, which I have opened, even though I had to follow protocol, but the protocol that I have to follow is it's failing me. And it's the National Healthcare Act of 2003. There's a policy guideline for the licensing of residential and or daycare facilities for persons with mental illness and or severe or profound intellectual disability. We know that guideline is highly, highly impossible or very difficult. It can actually make it impossible for you to actually set up something for your child. One, rezoning. How much does it cost to rezone a facility? Municipality wanted 50,000 that I have to pay the town and regional planner. Because if that property doesn't belong to me, I'm not going to get licensing. As I was sitting and thinking, oh, now I've got the town and regional planner whom I paid 50,000 to get the licensing, I have just gone through all the stages. The advert was taken out. The ward councillor opposed my application. I had to write a motivation letter telling her that what must I do with my son? Where do you want me to take my son? Because there aren't facilities for autistic children. Now I also got another bill of 178,000 from the same municipality asking me to pay for water, bulk use, to pay for electricity, to pay for road use, for the very kids that I want to help, because I bought a plot with the understanding that I'm going to assist the very same community that requires the service. The very same government wants to extort money from me. This is very depressing, and I'm speaking from the heart because I felt like quitting many times this year. I am a mom who is now also facing some other mental and health issues because I have to see to it that my son is well taken care of. But if we all working in silos, if we all making these policies without engaging with communities and seeing that mental health is not just people with severe and intellectual disability, but there's autism and it's rising, and there's going to be a lot of burden that this autism is going to place. So I'm sitting here and I'm saying someone has to help me. There is no way I'm going to pay that 178,000. If I have to go to the court, human rights, I will go, but I'm not paying 178,000. Someone has to do something that our children are well taken care of. Thank you so much.
All right. Thank you very much, Namasoka. Yeah, that's a harrowing revelation. And I know one of the members was whispering to me that we might have to apply ourselves to that. So I think we'll follow up. I think we may need to follow up. Can we then take number 5?
Okay, thanks. I'm here. My name, I'm Dr. Dainanguenya. I'm an educational psychologist, and I am working now with Wellbeing Africa. So as an educational psychologist, I'm always assessing children. I can really agree with what the lady is saying, because we are seeing children with autism. And fortunately, I still remember during when Mr. Litsufi was still in MSc, there were many schools where they were opening autism classes, so that now each and every district is having an autistic class. But the care is still not so up to standard. And then what I just want to say now, before I just give my input now here, we can see that there is portfolio committee on health. There is portfolio committee on education, portfolio committee on whatever. I don't know whether there is any portfolio committee on the economy as to how the people who are suffering in our country can be able to be alleviated from the poverty, whatever, which takes care of the economy, how people are able to access with all the resources that we have in our country. We're having gold, we're having diamond, we're having everything. But now we are poor. What is happening? What is the government saying until today as we are seated here with all the resources that we are having, where our education is not even geared to our resources? Instead, our resources are being taken out, and then from there we remain with nothing, and the government does not have any portfolio concerning the economy of the country, how to uplift the people, because we're having mental health now. If I'm hungry, I have nothing. Tell me, I'm stressed up already. Mentally, how will I survive? Because I'm worried, where will I get the next meal? How will I take my child to school? Another thing that I just want to say, you alone as health, you are not going to go anywhere else unless all the other parties are also involved. This is a systematic problem. We need education, we need economy, we need social development, we need everybody, so that we work together, so that wherever that you meet, can you please be integrated to a point as to how to address. We're having now the people who are busy, the drug lords. We're busy not preventing the very people who are bringing the cartels that are running this country. We are not saying anything, but we want to put money in helping those children who are being drug addicts, and we are leaving the drug lords, the guru who is out there. We are not doing anything. What are we doing? We are wasting money. Our kids, some of them, now, some of the information I understand now, children at the universities, we'll find that now they are struggling, mental health, whatever. We'll find that the child got an NFSAS. From there, that NFSAS did no longer continue to pay. Somebody took that money. They were not given, so students are left stranded. Then can you see mental health? And then we're having the media, which is busy now, destroying our children, destroying our communities. And then we're busy. These people have, it's as if now we are held hostage by whatever that is happening. So people, what I'm saying now, I still remember as a health organization, we were helping some of the healthcare workers. You know, when we were interviewing, counseling those health workers, they were crying that now we are not given even a place where to work. They are always checking now, people are HIV positive, whatever. So we are counseling the healthcare workers. They don't have any place where they can even put their bags when they are going there to work. The amount of work that they are given, there's the type of money that they are paid by the Department of Health. It's really frustrating, actually. So those healthcare workers who are in the front line to work, to support, they were not taken care of. They were not paid properly. They were not having now so many things so that they can deliver the services. So we are now pleading with this, that now, actually for me, I cannot even come with, I written the recommendations, what could be done here. If you need them, I can just email you so that now you can have them. But I'm from Wellbeing Africa, and I'm working as a psychologist, assessing children, seeing those kids with Down syndrome, with autism, ADHD, everything. The parents are carrying a lot, those who are having children with now disabilities. And then where will it go? It's obvious. Those stress levels will add again to another mental health problems, because mental health is more than mental illness. We are still having those who are ill mentally. And then now let's not increase the mental illnesses that we're having because mental health is not taken care of. We need to educate people, but the government, please, because we're having even the MEC here, people who are in government, can you please have, in your portfolio committees, can you please talk about the economy?
All right.
What is happening so that people can be uplifted. If people have food, if people can eat, they can stay, they can have a house, whatever, and also addressing the cartels who are running drug lords, that we can help. Thank you.
I don't want to do that, but we also must manage that. I appreciated when you said you were going to give us some recommendations, because ultimately, after these engagements, we're also going to consolidate, and we'll share with you the preliminary report so that you enrich it. But we'll still take your input so that it constitutes our framework in guiding our oversight work, so that with every one of our interactions with the department, we can still follow up on the issues that you are raising. Can we then go to number 6?
Good morning again, and all protocols observed. My name is Gerard Grobler. I'm a professor at psychiatry at Steve Biko Hospital at the University of Pretoria. I've got 6 points to raise. The first
I don't think we got the name, the surname?
Grobler.
Oh.
The first issue is around human resources, and I think that's been extensively mentioned here, and that remains a critical issue. The second issue is the integration of primary healthcare and specialist services. And again, it's not unfamiliar, we know, but there's implementation gap. So we all know what the problem is. It is bridging the interaction between the primary healthcare sector and the specialist services that we struggle. Up and down referrals, the integration of mental health services into district level care, as well as district hospitals, and then upwards into specialist services. So it's not that we don't know what the problem is, it's the implementation. That's the issue. The third issue I want to raise is the non-availability of medicine, specifically EML medicine that is on contract. And so that's a significant problem. If we have patients that are diagnosed, we start them on treatment, and then medicines are out of stock. On contracted medicines, that there are contracts to supply, we're not talking about motivation items. What happens then is we have to do buyouts. And then we have to apply to the institutional PTCs for a buyout. That comes from the buyout budget of hospitals for EML medicines, which places a burden on the hospital's budgets. And it seems that the hospital is overspending on buyouts, but it's for EML medicines. The next issue I want to raise is child and adolescent services in Gauteng. And I know it's been raised here, it's been mentioned, but specifically children in crisis. So I really respect and honor the NGOs that does residential care, that has day programs. But our particular concern is young people who come on account of substance, but they come to emergency units and they're in crisis. and to get them into care, whether that is in a Tara or at one of the other facilities, is a real concern. What happens is that these kids end up in the EMUs of district hospitals for days, which is inappropriate places. It's a mental health it's a human rights concern. It's a danger to both the staff, the patient, and other patients. And it's typically the teenagers around 12, 13, 14. You can't send them to the peds ward. You can't put them in internal med ward. And we don't have enough inpatient units for adolescents in crisis. I fully agree with the previous speaker that spoke about the integration of substance use disorder treatments and psychiatric treatments. I do have to point out that there are distinct legislation governing the involuntary admission of mental health users versus substance use disorders. And that, I think, is a big problem, is the legislative risk. I cannot admit a patient in my ward if it's not under the Mental Health Care Act. Okay, so I can deal with the psychiatric complications, but for the substance rehab, I have to then refer the person out. And that is a significant problem, right? So if we want to change that, we have to change legislation. And the last issue I want to raise is the issue of screening. Now, we've been part with several other universities in South Africa, as well as a university in Zambia, university in Latvia, and in Finland, in developing a screening tool. It's called the MEGA tool. It screens for depression, anxiety disorders, PTSD, substance use, suicide risk in youth. We completed that project in 2021. Up to date, we have not been able to get that implemented in Gauteng. We've got a tool that helps us screen kids at the clinic, but we don't have access to it because it has to go through rigorous processes of being IT compatible and working on different platforms. But yet we're crying out for teenagers not being screened. The technology is there, the tools are there. We just need to implement them. And I'm happy to take that conversation forward as well. Thank you.
Thank you very much, Prof. That helps a great deal. Let's take our number 7.
Good morning. My name is Mbadi Makhalo, all protocol observe. I am from Hill SA. At Hill SA, we support young people with mental health services through teletherapy, advocacy, and mental health literacy training. And we also do provide peer mental health support. In terms of our recommendation, for me, it's already been mimicked, and I'm not going to spend a lot of time on that. Our partner, Dr. Nhlapo, did mention some of our challenges, but from our side, the first one is around being cognizant of the intersectionality of mental health. We tend to work in silos. When I talk about working with youth, we are in all the universities in Gauteng and in some of the high schools in Ekurhuleni, in Tshwane, and in the city of Johannesburg. People always look at us as in like, you know, you're dealing with this cohort of young people and what they have to go through or what is happening to them. It's as if it's not happening in the community. An example of that is I was invited by a vice rector of one of the universities and wanted us to talk about the services that we offer, and they were saying, oh yeah, suicide is a problem. We've decided to actually change the infrastructure of campus housing. They no longer have balconies because children, you know, commit suicide. And I was saying, but rector, the problem is bigger than the balcony. So I'm referring to this intersectionality of you just looking at a building and not looking at what's deep inside and not even thinking of providing us with funding for us to then help you. The other issue is, I think one lady started talking about it to say we cannot talk about a mental health policy without addressing the social determinants of mental health, and this includes poverty, gender-based violence, violence and unemployment. I think that's very important. And lastly is the issue of engaging with people with lived experience. I'm not sure, I've only heard from one mom who's talking about her son who's autistic, but I think we should have people with lived experience be part and parcel and really have them as experts for them to tell us how they would like to be served and what's the best way and approaches that we can support them. Thank you so much.
Thank you so much, Membali. Can I give Membali ma? Oh, Mbadi Makhalu. But, all right. Thank you very much. Let's go to number 8.
Good afternoon, everyone. My name is Mbali Nyati, and I'd like to also observe protocol. I'm a registered counselor by profession, and I'm the senior facilitator at Talisman Foundation. We are an NGO that caters for 200 residents for mental health. And I think I can echo with a lot of the people that have spoken, from Barty to Sadak and everybody. And I think also Dr. Grobler. We are facing a lot of challenges with hospital admissions at Talisman. We use Southland Hospital as our primary hospital. And I feel there's a lot of stigma that is among the hospital staff when it comes to hospital admissions. You know, we struggle. We just recently, we've been sending people for mental health issues. But when they get there, they might find that their iron is low and so forth, and then they start treating them for their medical problems. But we send their psychiatric medication as, you know, as we pack on a weekly basis. But the shocking part was just the one resident of ours, we had 4 of her boxes sent back. The medication was just dirmakar, you know, some given, some wasn't given. And they discharged, I think, after 3 to 4 weeks after putting on a drip for her iron. And she came back and she wasn't well mentally now, you know. So we obviously had to send her back. So it's been a long-going process where, or ongoing challenge that we have with hospital admissions. You know, at some point we are told that you know, basically they just fed up with us because there's too many of our residents at their hospital, you know. But obviously it's not just the hospital itself, but there's individuals that I feel need to be trained more on mental health care. Again, family support. The gentleman from Freedom Recovery also mentioned how family support is a huge challenge to NGOs. You know, I mean, we don't have a complete 200 patients at the moment, and I think I'll get to that one also. But from the 180 plus minus, only 20% of families are involved. You know, families visit, families take their family members to like holidays and stuff on like, you know, the holidays, Easters or December and stuff like that. But in essence, you know, we have our yearly AGMs, and literally only 2 or 3 families pitch up when we invite those families. So it's a big challenge, and you find a lot of the residents start absconding because they miss their families. So yeah, that's another challenge. Okay, and I also wanted to you know, we've recently been told about this new legislation regarding hospitals, like the tertiary hospitals sending clients to us, and they can only send patients that are already discharged, right? Where before, for example, Stokefontein used to send patients to us, whether it be involuntary or on an assistant basis. But now it's on a voluntary basis, purely discharged. So initially what we used to do when they send them on LOA, if they relapse in our facility, we can send them back. Because what we also noticed in the past few years, they would send people that are very unstable, that are not properly managed. So they get to us, and either they didn't give us all the information that we need to know about the person, and then we start finding out as time goes. And then also they're not well. So we don't deal with acute patients, but they would send people that are still acutely, yeah, what's the word? That one. So, but they would not be completely stabilized. So we are sitting now with an issue because most of the beds that we had already booked for patients that were supposed to come to us from Sterkfontein cannot come anymore because they're only sending discharged patients. So we don't know what's going on and how things are going to be, you know, because nobody really explains anything to us. So I think also maybe for a, if I can say like a, what? Sorry, I'm nervous.
Yeah, say it.
You mentioned it. To solve a problem. Yeah, a solution. So for a solution, could we also get an understanding on what's happening with this whole situation of sending people to us? Because obviously, you know, a lot of the times we are told that people are trying to make space for beds in tertiary hospitals. Obviously, we are here to accommodate people. But I think also if they could also send people that are stable enough for us to also manage, because again, if we can't manage them, we have hospitals to take them back to, which becomes like a, you know, a vicious cycle. And again, when we get patients, you know, from different hospitals, they are told, oh no, you're only going to stay there for 6 months, you know. And again, definitely, you know, we are not a long-term home, but bearing in mind that these people don't have families, so if they're going to stay there for 6 months, where are we going to send them out? We can't kick them out to the streets. So we end up becoming, yeah, a bit, yeah, frustrated as well, because, you know, we can't, no one wants to take people in different centers. You know, we also have an issue with the geriatrics, where we couldn't send people over 60, and we're not licensed for that, but we couldn't send people over 60 to like old age homes and stuff, because people don't want to handle mental health patients. So yeah, I think
okay,
I'm done.
Ghana, which facility did you say you are
Talisman Foundation.
Come again?
Talisman Foundation.
Talisman. Oh,
yes.
the Talisman.
Oh, and one more point, I think, because the lady also mentioned, sorry. The lady mentioned about being billed. You know, we are also being billed privately for water and electricity, which is insane. Because we're an NGO. I mean, our bill goes to the millions. So, yeah, we also please need assistance. Thank you.
Okay. Thank you very much, Mbali. Can we take our number 9 and then number 10?
Hi, so my name is Salama and I'm representing the Saeed Foundation. I'm also going to speak to the audience here. Thank you very much for accommodating us first and foremost, for all the professionals also with us. But I think we'd like to extend that reality to the team in the hope that we can have resolutions on mental health in our communities. I'm talking from communities in the greater Brixton area, where we can see many of the homeless roaming the streets, in the Westbury and surrounding communities, where gun violence, where substance abuse is obviously the main reason for mental health. But the capacity of facilitation seems to be not sufficient. As a result, we have some NGOs in the community, but what I find is a problem is the bureaucracy of documentation to many of the non-governmental organizations or the community-based organizations. So a solution for that would be the Department of Health the local clinics, the local hospitals, Department of Social Development, to work hand in hand with families, first and foremost. It is these families that is calling out to the health fraternity for help, to report. Many of the homeless, clearly, are subjected to mental conditions. How will they take themselves to the hospitals unless we have a helpline where we can report these individuals? So I'd like the committee to open up so that we as the community can call on the department to collect these individuals so that they can get the necessary treatment, number one, for themselves, but also to get them back and connected to their families. So I'd like to see more incorporation of the Department of Health together with its parastatal committees such as the SAPS, Department of Social Development, more working on an outbound patient treatment for families, for these patients, many of them that are on substance abuse. Many of them are youngsters as well, subjected now to gun violence. Many of these communities subjected of poverty, unemployment, resulting now into emotional damages that is resulting to mental health. These are all the evidences that has been making headline news in communities like that, and unfortunately, the capacity of the facility as Helen Joseph cannot capacitate all these individuals. So we'd like to see more interaction with CBOs, NGOs, having these trainings from the Department of Health incorporated into these organizations so that they can also work together with the Department of Health to filter treatment further down. Thank
All
you.
right, thank you so much. Thank you so much for that. I think the team says they missed the name for record because we're also recording. If we could just...
Okay, so my name is Salama Jadeen and I am from the Said Foundation.
From the?
Said Foundation.
Oh, okay. All right, thank you so much. And finally, let's take our number 10.
Thank you very much. My name is Debbie Kupolati from Wellbeing Africa. Yes, Kupolati from Wellbeing Africa. I will be talking briefly from the perspective of what we do, and my colleague has spoken generally on it, and I will just zero in on what we do. We train community health workers because we know that community health workers, they are the arms of the clinics in the communities. And so we train them to capacitate them to do what they do effectively. And so one of the trainings that we provide is psychosocial counseling support for them. And in the course of doing that, we discovered that even the community health workers themselves, they need support, even in that regard. So we have come up with this recommendation, which I will just briefly read in order to keep me within my short period of time. So we discovered that community health workers themselves, they face emotional fatigue and burnout due to continuous exposure to distressed community members without adequate psychosocial care. Therefore, we recommend institutionalizing regular psychosocial debriefing, peer support groups, and wellness check-in for these people. And to strengthen their emotional resilience, we believe that strengthening their resilience will improve motivation, retention, and their quality service delivery. Two, we know that community health workers, they play a vital role in the early detection of mental health cases. So we recommend that formalizing and scaling community health worker-led community mental health screening and referral system through basic mental health literacy training, and providing a simple screening tools and clear referral protocols. Because we believe that this will expand the reach of early intervention and reduce their treatment gap. Thirdly, which is the last point, from our experience, we have found that there is this financial constraint, especially lack of transport money, that prevent clients that are referred to take up these services. And therefore, we have recommended piloting a transport subsidy or community transport fund in collaboration with NGOs, local government, and social development partners to improve access to mental health services for low-income clients. Thank you.
All right, thank you very much. We may have to receive a more expansive detailing of that proposal from the well-being, so that when the department considers it, it also bears its own unique models. So I think let's appreciate those submissions. And thank you very much. I think we had noted 10 hands. We still have got a bit of time. So I want to check whether we can take 5 more hands. 5 more hands? Or the MEC will is going to have a meeting. So maybe let's respond. Maybe let's get the department to respond. And then if we can save up on time, we're going to take more hands. Because this is a stakeholder engagement. Even when the MEC would have left, I know we still have got managers from the department, isn't it? Because we want to hear more. The intention is not to have a mechanical and passive engagement. We really want to internalize some of these observations so that ultimately they get to inform the overall programmatic outlook of the department. So, MEC, can I hand over to you? And maybe let me just indicate before you step in, MEC, we also have got members who are going to join another meeting. So I know there are pressure against time as well. And we must thank them for their discipline of availing themselves. They will go at a batch. They are not going to go all at once. So they will go in intervals. Thank you very much.
When I was a chair of chairs at the legislature, the meetings used to start at 1. So intervals means that they are going to be ready for the 1 o'clock meeting. Then the chair of chairs will fight you. No, thanks, Chair, and let me greet all the leaders that are here from various organizations, and greet yourself, Chair, with the members of the committee that are here. All of them. Anyway, your committee is always full. All the members are always present in your committee, which is a sign of being a leader that is hands-on, Chair, that wants things to be done. Chair, I'm not going to comment in a number of things, but I've noticed what the colleagues were raising from various NGOs in terms of what we should be doing as a Department of Health. And I think part of the things that they are raising, some are working with the Department of Health. They know exactly what they are talking about because we've been working with them. But the key thing that they are raising is the improvement on the services that we should do. And I think in the presentation, Dr. Slepe and Dr. Ndate Pitsi, it talks about the issue of capacity, that we all know about it, that you have raised even the issue of capacity in our institutions, which, Chair, we are prioritizing it because we have seen the need, indeed, of integrating our services, especially the clinics and at the district level, as Professor was saying. But there are those cases then people just throw themselves to the academic hospitals, which it's a problem, we know, but unfortunately, you can't turn them back. You have to treat them and then we can refer them to other institutions. The other issue that we have experienced, Chair, which I'm proposing that in the next meeting, after this meeting, in your recommendations, highlight this serious one of us integrating our services. The Department of Health, the Department of Social Development, the Department of Education, the Department of Sports, Recreation, Arts and Culture. So for me, those are the 4 main departments, which are the portfolio committees, Mama, as you were saying, that we must work as a collective on these issues. Because the issue of drug abuse, it's not only related to us, we're part of the mainstream. The Department of Social Development is key in that specific area. And we have seen quite a number of inputs that some of the people having their NGOs that they are dealing with, but again, the issue of substance abuse comes up, and which means we have to make a follow-up then. The next meeting that you will call, Chair, it will be that meeting which the legislature allows you, that you can have a meeting with the 4 committees and come up with recommendations that immediately then will have to work to in implementing those recommendations, because one of the colleagues said, we're not implementing our recommendations, but the implementation part will be done once we start working together, not in silos. And again, it was raised by yourself, that issue. Then it will help us even on the issue of resources, because we're going to share the resources. DSD, which is the Department of Social Development, have some nurses that they have. We have our nurses, but if we can combine those nurses and work as a collective, that will help us. So that's why, Chair, I'm emphasizing the issue of us working together. Then we'll do our part, which is more on the medical side that we have to provide to the patients, which we are doing, by the way. And Prof, I thought, because you understand, even if there are other medication that we don't have, there is supplements to those medication, which sometimes people think that if it's there, it's not working the same way it will do the other schedule that you don't have it. Because sometimes it's a national treasury that will determine what medication we will have, and it's finished, but we'll have a supplement. There is no way that will stay with the patients without a supplement in the medication. And I think if we can just, Dr. Slepe, emphasize that with Prof, because people will think that when we don't have medication, it's completely nothing. Their children or their mothers or brothers are not treated. They are treated, but with a different schedule that will be there in the platform at that particular time. So that's what I wanted, Prof, if you can just raise that, because it's unlike we don't want to do services, because the next thing members of parliament are going to follow me with a question that says, at Vescopis, you don't have medication, or at Steve Biko, you don't have medication. We have medication, but is the supplement that you will not have at that time, which is finished at the national, then you will take from your money indeed, as you were saying, but it doesn't mean that you don't have money at all, that you can buy that medication. But the problem is, how long will you buy that? Until then, the next batch will come and then it will be delivered. So those are the questions that needs to be clarified when we're having a meeting like this one, Prof and Dr. Slepe, so that people don't leave the room with a different information. Then when I'm asked in Parliament, I answer honestly, and then they will say you are lying, because when we were together at Brixton, this is not what you clarified. So Dr. Slepe and Prof, please clarify this, because you are my mouth, you are me. When you are here, you are helping me to answer some of these important questions that colleagues are raising. Then there was the issue of community health workers that is being raised. We have employed now community health workers full-time. All those who have matric, they are employed, they are at level 2. This happened last month. It's only going to be implemented now. But at Gauteng, we're the only province that took money that we don't have and employed community health workers. It has been not budgeted for, but we made means that they are employed. So they are employed. Other provinces are starting to follow Gauteng, because they were angry anyway from that Gauteng has absorbed them, because we absorbed them because, Mama, of those issues that we are raising, of the problems that they were experiencing. So we're trying now to sort out even the issue of accommodation, because remember, when you're a contract worker, you can't have an office space. You can't have things that you have, especially if you're employed to go outside and do door-to-door. That's why they won't find the space for their beds. Now we're insisting that we're going to look for little corners, whether in the district offices, in the clinics, or in the hospitals that are nearby, so that they can have office space, so that they can sit. In fact, there are leaders in the regions are having an office space now in my floor. I've given them part of my boardroom so that they can use it, because even themselves, they didn't have even space to use to write their reports. But now we've accommodated them so that they are able to coordinate the activities in the regions. But again, we have trainings that we're doing, but it doesn't stop you, Wellbeing Africa, to train them if you have other opportunities that you will get, because you do get money from other outside organizations that are sponsoring you for training. So you can bring those training to complement our training, but we do have trainings that we're doing as a department to our community health workers, especially as counselors. They're graduating, some of them, some have graduated last year. I was part of the graduations as counselors, because when they go out to communities, you expect them to live up to a certain standard in terms of the work that they must do and touching of those patients. What you are saying of even screening, or even, that's something that is on the pipeline of training them how to screen, so that when they arrive, at least they are able to screen a patient when they arrive to the communities. To stay. You have seen the video in 2022, December, on the 16th of December. I don't forget that day because I was traumatized. Of some of the patients, 16 patients that arrived at Tembisa, and they were put on the floor, some of them. Then we had to immediately organize that there is an extra ward that we organize in Tembisa. So those patients are not on the floor again. So there are certain incidents that have forced us to do that. And I think in this room, you all believe that we're not doing that because we don't have anything to do. We did that because we know that those are your children that are there. But again, the issue of drug abuse. Go to Kalafong now, go to Jubilee now, go to Mamelodi now, go to Helen Joseph, all these hospitals, the CEOs are here, including Steve Biko. Those kids are on drugs. Those are the drugs that has made them to be in those conditions. And how do you do? Then you have to treat them. You can't say, no, he was on drugs, he was involved on drugs one side, and then you want these ones. All of them must be treated. They deserve to be treated. Then there was a colleague that raised the issue of the autism schools. We have autism schools in the province. The Department of Education is having those schools, but we are not discouraging people then who think that they can have these kids and take care of them. Like example, it's because of the need that when you see your child, you say, how many that must be helped? Then you raise that extra hand, but out of that extra hand, then government must start assisting her so that she is in a position to have the support from government, Chair, which I think you have noted the issue, okay, that she will definitely be referred to the departments that must help her, especially on the issue, if the one on rezoning, I think you'll talk to the municipality where she comes from so that she can be assisted. And I think, Chair, I will end there. We're trying as a Department of Health to normalize the environment, but the workload is too much now in terms of those kids that we found that are coming to our hospitals. But the view is, even if you find them at Dr. George and Steve Biko, which are the academic hospitals of Bara, when they are there, there is an acute mental health ward that they must be treated, then we can refer them to Vescopis and other areas. Thank you, Chair. I'll give it to Dr. Slepe.
Thank you so much, MEC. Thank you so much, MEC. Truly appreciate your responses to some of the issues and those firm commitments on a number of areas, I think as ventilated by participants here. Could I just maybe then take, is it Dr. Slepe or Dr. Bizi? Just on the other, okay. Just on the other points.
No, thank you, Chair, and thank you, MEC. Yeah, Chair, the issues that I would then talk to before...
maybe let's do that. I know the MECs were excusing her because of other commitments. I think we must just thank you again, MEC. We truly appreciate it. You did indicate, and I think we tendered the apology earlier on, that you would be arriving slightly late, but also that we would have to excuse you. We appreciate. I think, born out of these engagements, there will be a report that we will share with the department. And of course, as you know, the committee will expect that the report be actioned, you know. So we'll structure it in such a way as to to have some follow-up mechanism so that everything that has been said here is not lost, outside of this meeting. So I think in so saying, allow us, MEC, to excuse you, and thank you very much. All right, let's continue. We can proceed, sure.
Okay. No, thanks, Chair. Let me start with the issues of, is it talisman care in around South Rand. We've noted the issues that they have talked about. We would then link them with the CEO of Sterkfontein and the CEO of South Rand Hospital, so that then they could start those communications and engagement. The issue of medication, Chair, I would go
but
to...
what we want, so that we don't want to pass the buck. The department is the central authority. It still has to play an oversight role over whether CEOs at that level actualize on those commitments. Can we do that?
We will, Chair, in terms of ensuring that those engagements take place. Then the issue of medicine availability in the department, Chair, it's around 96%. And then there are, as Prof has said, some of the medication that would be on contract. And what would then happen sometimes is that those medications, when, as a department, when they are on contract, the companies would sometimes play some games with that. Because what happens is that, I want to explain how then we come to buy them as a buyout. When that happens is that on a contract, the medication would be cheaper. But then if it's not available, then we would, as a department, have to buy it as a buyout, because we cannot allow patients to go without medication. And then as a buyout, the price would be then revert to a normal price, a non-negotiable price. So most of the companies would declare that there is no medication available, and then we would then have to go on a buyout. But in that process, we also write to National in terms of reporting those incidences to say we had to buy medication on buyout, and that is at a higher price because we now go to another company. And in some instances, we know that there had been also nationally no ingredients for some of the medications. The issues of PSI, as a department, we started a process of reporting on patient safety incidences. This was launched by National formally in 2017. This is a matter of a culture change where we encourage our staff to report on any incidences that have happened, so that as a department we are able to take accountability, resolve them, and our staff can learn from those incidences. So we as a department encourage staff to report these things so that then we are able to learn. The numbers, yes, as it has been reported, they have increased, and we are as a department able to categorize these incidences as they happen. Firstly, in terms of severity, whether is severity 1, 2, or 3, and also in terms of how this incident happened and what was the cause. And then with those, then we get to resolve them and come up with recommendations. And then that is reported nationally because it is controlled nationally. And our quality team then has to make sure that the quality improvement plans based on those are being implemented. So we encourage that our staff and our managers should deal with these patient safety incidences and resolve them within 60 days. And if they are not resolved within that time, we as a department as well measure that and be able to know which institutions are not doing that. So we are progressing on that matter, Chair. In terms of community healthcare workers, Chair, we should remember that previously these community healthcare workers were at different systems. They were not under one unit. But what we have done now with community healthcare workers, we have integrated them under Mr. Pitsi to say they are going to be able to collaborate and don't work in silos. And as we are doing that as well, we are also training them now in terms of also integrating into mental health care, because we have realized that there is a bigger gap in terms of how we manage at community level in terms of these patients at that level. Then I would also, the issues, Chair, in terms of also what the department we are in achievements. Chair, we know that we have a problem of overcrowding in our hospitals, as it is alluded in this meeting. And then we acknowledge that problem, and as part of that, that's why we had then came up with the expansion of the bed capacity that is there, and that has assisted a bit, not 100%. There's still a lot of work that we need to put in terms of ensuring that we bring more bed capacity. And that's why we also increased the contracted care at the 2 facilities that are trying to assist us to decant patients that are now stable, so that we can move patients that are in our accident and emergencies to the beds that are available. So there is still a lot of work in progress. Part of that is the renovation of, we have a plan, how we are going to then utilize Cullinan Hospital in terms of also providing more care at Cullinan. The business plan has been approved by the HOD, and we are now going to start embarking on those issues, Chair. Thank you very much. I think I've covered most of them, the deputy, unless there are others you've noted I've not covered.
Okay. Members, is there anything from your side? Just briefly. I know there's a number of points, but we'll come back to those. Let me just quickly check with members. Anything quickly? You can come in, Member Higlin. Or you also want to come in? All right.
Member Evans was before me, Chair. So
Okay, let's take it that way. It's okay.
Thank you, Chair. Thank you, Chair. Sharp and concise, as you said. On slide 8, you mentioned something about bed availability. When we went to Cullinan, it was slightly overcrowded. So I'm just wondering, are there beds now for our mental health patients? On is it Mr. Souls, am I correct? Mr. Souls, you mentioned something about the different types of drugs that our children get hooked on. If you considered lean as one of the drugs that also, that plays a vital role, and I'll tell you why. I live in a community that's infested with drugs, right? So please look at lean as well. And I don't think our SEPS pays much attention to the lean, to the drug lean. And also, you mentioned schizophrenia. Our children are diagnosed with schizophrenia. But what I've noticed is that there is also bipolar. A lot of people goes in a drug addict and come out diagnosed with bipolar. And therefore they take advantage of this and actually apply for SASSA with that diagnosis. On your community outreach, there, in community-based services, there should be more of that. And it's actually very sad that we have these challenges, drug challenges in our communities, and there's not enough rehabilitation centers within our communities. That is also a point that needs to be taken very, very seriously. And family support, because I live in a community where there's a lot of drugs, I can say some families actually takes a sigh of relief when a child is in rehab because of the trauma that the child actually puts them through. I can tell you that this morning, 3 o'clock, we had one young man swearing very, very loud for all of us to hear. And imagine, I can only imagine what the family actually goes through. It also, it's said that someone mentioned drug lords. One of our doctors, I think, mentioned drug lords. And that is really where our children become dependent on drugs because they sell it. And in order for them to receive payment, they are given drugs and they become addicted to it. Then our rehab centers actually faces the problems that we have in our communities. What I'd like to say is to everybody here, you guys are doing a sterling, sterling job. I cannot emphasize enough how much education, as our professor mentioned, I cannot emphasize how much education needs to go into our communities with regard to mental health and drug addiction.
Thank you so
Thank
much.
you, Chair.
Thank you. We must manage time.
Thank you, Chair. A lot of what I wanted to say was actually covered by Member Evans. And my primary question was to really ask, how effective is the decongestion program at Cullinan Hospital? How well are we actually managing moving people out of Cullinan to step-down facilities, for want of another word, or to NGOs within the mental health space to make space for new people to come into Cullinan, bearing in mind the constraints that you have? I'm very pleased to hear that the new acting HOD has approved the business plan and that we will be able to move forward with the refurbishments that were so desperately needed at Cullinan. But my question really was about the decongestion program and how effective it actually was. And then also just to comment to the lady who has the autistic son and the program that you're trying to run. If there is anything that we as the community and we as the portfolio committee can do to assist, please druk op ons knoppies. Come and see us and see what we can do. And that is, in fact, if I may take this opportunity just to thank everybody on behalf of the community and on behalf of our portfolio committee to say thank you to absolutely every one of you who has come through today to share your stories with us, your successes, your challenges. We, as the Portfolio Committee on Health, are here for you. You have our email addresses because you got the invitation to engage today. I'm asking you on behalf of our chair, Ezra Letswalo, please make use of us. Our job as oversight is to hold the executive to account, number one, but number two, it's to be your conduit. When you have challenges, make use of us to help address your challenges in a way that makes us effective in the lawmaking process. Please allow us to help you in the way in which we become effective lawmakers.
All right.
Thank you so much.
Thank you so much. Memora, you want to say anything? You're fine. All right. Thank you so much for those remarks. I quickly want to lift up some few points, Doctor. And I'll start with Ms. Patel, because she raises quite a number of critical issues in respect of what the presentation represents. And we may have to expand a bit, because at some point we need to get a more pedantic sense of a budgetary constraints as against the demographic profiling, but the overall reading of the extent of mental health presentations in specific districts, and break it down so that we understand the analytics of the mental health cases for what they are. So if it's anxiety, depression, and we understand the prevalence, I think that will assist a great deal, and I'm in agreement with her on that one. And then Mentlabo also raises a critical point, and it may not necessarily be something that falls within or solely within your purview, so it's still your responsibility. But possibly it's one that needs to be dialogued at a national, a level. And I know ordinarily the MEC does present itself before the National Health Council. The issue of Section 33 of the Mental Health Act, it's a nightmare, when you consider what a mental, and I think another participant raises. Because in instances where you are dealing with the homeless persons, the encumbrance of having to dispose of affidavits, and this person is untraceable, can be nightmarish. And so at some point, as part of the notes that the MEC may have to sponsor at the National Health Council, it's the issue of the limiting effects of a Section 33. I mean, it's an old act. It's a 2002 piece of legislation. Surely, at this point, we need to reflect, because mental health care presentation in 2002 may not have been to the extent that they are now, because the floodgates of drugs are opened, people are displaced, families are broken down. So I think we need to understand that context, because if we don't, we're always going to be hamstrung by the limitation of that prescription. I think it's something that we need to quickly reflect on. And then Matt Chambers also raises an issue around, and I'm not so sure whether in your response you may have mentioned it, about the re-invoking the functionality of the mental health task teams, whether you are still facilitating that convergence amongst the different role players. Because our NGOs, community organizations, academia, research institutions are quite critical in our overall and holistic response to the mental health epidemic. So I think one of the things that we are going to be monitoring is that, the frequency of your interactions, whether there's a level of adaptability of some of the inputs and recommendations that they would be sharing with yourselves. So that we carry this voice. Because often at times when you operate on your own or in a silo, you are likely not to hear some of the expressions from the community. Then I suppose that they constitute social capital because they are representative of the observations that have been made on the ground. At times when you are a policy implementer, it's easy to fall into the blast of how policy gets to be actualized. Because the things change. Society is not static. There are newer realities, newer experiences. And I think sooner we appreciate those realities, the better. I also thought, Me Masuka raises a fundamental point about the overall continuum of care, and relational continuity, if you will, such that when we know that this child has got this, challenge intellectually, how does the system cushion the child, the patient, the family? Because how the formulation around the continuum of care is that it's all encompassing. So it also locates the family, because if the family is left out, post the treatment, they may not even have the ability or the know-how of how to manage that situation. So you should have some level of a mechanism to also bring the family into the centerfold. And I know it does happen, but possibly the manner and style in how it happens might be inconsistent, or it could be sporadic. And I'm suggesting that we need to revisit the overall framing so that we don't have what has been characterized by Ms. Masuka here. But I tell you, Prof raises something quite important as well. In the overall deliverology method. And one of the things, and I know I assisted one family some 2, if not 3 months back. They've got a young man who suddenly developed some mental health challenges. And then the family, reached out to me, and I said, well, let's reach out to one of the facilities closer to where you stay. The challenge was that the mother stays in Pretoria. But the child was staying with the father around these parts. And so we redirected them to go to Helen Joseph. And this young fellow was in Helen Joseph in the 72-hour section. I don't even want to call it a unit, because it's a two-way passage thing, arrangement. This boy was there almost a week of having been there. And then out of anxiety, out of the mother also falling into a similar mental health challenge, out of the situation of her own child, the doctors recommended that there's a bed in Southend. And so this boy went to Southend. And distance, accessibility issues for the family became a problem. But I'm sure you know what the challenges are in Southend. And so this boy had to be redirected, Prof, to George Mukar, so that at least the mother is a bit close. So the swinging in the receipt of a treatment might actually exacerbate the situation. And I'm just raising this as just but one example. But ordinarily, as people enter the system to primary health facilities, no sooner than they are there, even without running through, thorough assessments And it could be that at that level, we don't have the right kind of, skilled personnel. So you do have a personnel, trained nurses, but not to the extent that would be required. And I suppose those are but structural challenges. No sooner they are seen at that level, they are referred elsewhere. And elsewhere, they are referred. So you have got a protracted referral trend, which causes some level of pervasiveness in the consistency in the receipt of a treatment. So I thought maybe what needed to be articulated here are treatment guidelines in respect of mental health care presentation, but also treatment differentiation. Because my sister is right. I think one of the participants is right. A child with autism is taken to a facility. And I'm not so sure what happens in the value chain of them receiving treatment. Because it does happen that in certain instances, and I'm not suggesting that it's across the board, but in some instances, and I've seen it in other facilities, a person who comes in with a depression, anxiety, post-traumatic, autism, or any other, mental health issue might be the same, bandit the same. And remember, patients are not the same. There are those who are prone to outbursts, and you will find that they are put in the same, room as would be those that are presenting with mild, symptoms. And I'm not so sure at which point do we then differentiate. Because when you place a patient who has got mild symptoms with those who have got severe symptoms in the same room, it can easily exacerbate, the situation or the condition, if you will. And I know the limitations of infrastructure. The department is currently responding to that. But I'm saying we almost need to think about how to mitigate those kinds of challenges. And I know my sister also requested that let's shed more light on schools that could possibly assimilate, young people with autism so that they are assisted there. And I know there's a number of those schools, but how you interlink with your programs as the department also becomes crucial. I suppose it's part of the overall holistic approach, methodology. I think I would have spoken to what the Prof would have raised, but safe to say we are in agreement with a number of points, including addressing the issue of stigma. So it's a broader social issue, which requires a multi-sectoral, a compacting. It's not something that easily resides within the department alone, but you need to run awareness programs. And there's nothing that prohibits stakeholders who are here to also formulate themselves on the kind of programs that they can partner with the department so that we maximize and heighten, health education in respect of these issues. I hope I'm not leaving out anything. I've spoken to the issue raised by Member Ali over the bureaucracy of a documentation of, homeless patients. It's exactly that issue. And I'm in agreement, David Bolat, on support to community health workers. Quite a crucial intervention, because we need to always ponder the question, who tends to those who are tending to others? Ultimately, the workload, the pressure, gets to them. So I'm in agreement with that specific issue. So allow me to leave it there. I just want to assess whether there's still an appetite to raise maybe additional issues, just 3-4 hands before we wrap up. I see 1, I see 2, and my sister 3, 4, Yeah, we're going to give you a minute each. Ne? Are we okay? Loen? Yeah, we're going to do it because, you know, we often rush ourselves through dialogue. We don't afford ourselves time. Lunch is important, but we can always skip lunch, isn't it? So let me know those hands. I'll start here. 1, 2, 3, 4, 5, 6, 7, and 8. Hey, Mario, you are a lord, man. And 9. A minute each. Let's agree to a minute. And 10. So we've got 10 new hands. I've got an appetite. So we've got 10 hands. We're each giving you a minute. Yeah? Okay.
I'll skip the greetings since I have a minute. I think what I'd like to maybe bring to the attention of the committee today is I heard the issue about posts, that a number of posts have been filled, but it doesn't sound like these posts were at the hospital levels. They were mostly at the district levels. So it means within the hospitals, we did not really benefit from those posts. And the other thing that I want us to look into is the vacant posts, especially for all the psychologists, clinical support and therapeutic services that have not been filled in our hospitals. And with that means we are not able to provide the services. And it's important for us within the hospital to actually have psychologists that are designated to service our psychiatry units. Because the psychologists that are in the hospital are servicing the hospital as well, outpatients and everyone, which limits the time that we are able to spend with our mental health users in the wards, and even come up with programs. I think they mentioned that we don't have programs to stimulate our mental health care users. We won't have those programs if we don't have psychologists, OTs, that are based in the unit so that they can develop those programs. So those are some of the things that we need to look into. And I know we're decentralizing mental health. We want us to really focus on the district level, but the problem is that at the district level, you find psychologists, OT, speech, sharing one office. That means they can't see the patients. What happens then? The waiting times are longer, and then the patients end up at our specialized hospitals because the waiting period is long. They don't have office space. I think it's going to be very important as well to strengthen district the communication with our communities to understand that they receive the same quality of mental health services in the clinics as they would in the hospital. So they really need to start going to the clinics and utilizing those services because they're available. One last thing. Our transgender patients, I'm sorry, this is important, because we really struggle when we have to admit them in our wards as well. Thank you.
All right, thank you very much. Let's take number 2. I want us to move a bit quickly because, yeah, we are pressured outside.
Thank you. So very briefly, just on the matter of application for admission, it is true that the Mental Health Care Act prefers that family members, but we don't forget that the Mental Health Care Act 32 and 33 talks about associates, it talks about guardians, it talks about mental health care providers that can make the applications. So it's not only family members.
Yeah, we're saying it places an additional burden on those that are not necessarily immediate family, you know, and we've seen that frustration across the board, you know. So beyond the family, I mean, if it's mental health care provider, in other instances, for you to qualify to be a guardian, you must have been enrolled as such. But if you want to take an interest in somebody that you may not be a guardian of, so there are those specific challenges. But let's take number 3.
Hello, I'm one of the community members. And family member that's has mental illness. So I just want to know, they go to the hospitals, all they get is medication, no counseling, no nothing. Nobody comes out to find out what's wrong. Every time they go to the hospital, they just get medicine. The medicine make them sleep. They're forever sleeping. So I want to know, can they get counselors out for these people? Because it's been going on for years now. She was she worked at a bank, she did everything, and now all of a sudden she has a mental illness where she just gets medicine, but no counseling, no nothing.
Okay. Is it number 4? No, number 4. Yes. Let's take number 4.
Afternoon, everyone. My name is Sister Crystal. I'm from Freedom Recovery Center. I just want to highlight that you don't get a normal substance user anymore. Each person comes in with a dual diagnosis, whether it was depression because of their home circumstances, or they use substances to placate psychotic symptoms. Most of the time in communities, because there is no awareness campaigns around, people don't know that if you leave psychosis untreated, it leads to, like Honorable Member Evans said, it leads to schizophrenia, it leads to bipolar. So these people don't get help in time. By the time they come to us, they are psychotic. Then we have to send them to the tertiary hospital. They stay a few weeks there or even a couple of days. And now, thank you, Professor, for that insight, because now I know why they are discharged without medication. They are discharged without medication. We have to follow them up with a local clinic. Local clinic gives us a date for 6 months' time. Within those 6 months, there's no medication. We cannot discharge these people, but we cannot have a conducive relationship with them because they are not on treatment. I have a guy there now. He came, I was just looking now, he came in August. He came with electrolyte derangement as well as substance use because the family didn't take him to the clinic because he had diarrhea. He came with nappies. I had to send him like that to the hospital. The hospital treated him. I sent him to the clinic for a follow-up appointment. He still doesn't have a follow-up appointment with the clinic. He still doesn't. And that is the challenge that we as substance use rehabs, that is what we face. With my colleague here, over here as well, I'm one of the few professionals that have personal substance use experience. I was in substance use in Cape Town. I'm from Cape Town. And my colleagues, they do not see it as something to be sympathetic over. Because some people, they just think, okay, they're in substance use, can't you just use their mind? But we need awareness in teaching our professionals, especially nurses as well, that substance use is real and substance use it's not a side thing. It's not a side thing. I have the passion for it because I've been in it. So where I'm working, it's where I want to be. Okay. But yeah, that's the gap between the clinic and the hospital and NGOs it's not there.
So treatment gap, if you will, or lapse. So thank you very much. Let's take number 5.
Thank you very much. Quickly, Chairperson, in the spirit of resource sharing and the current interim sort of model that we have, we do have funded NGOs that have been funded for certain districts to really take up our substance users for the outpatient program that I will keep pushing. But we struggle with MOUs in some of the districts. We've got great pilots like Yeovil Clinic that I have been a part of, as well as Johan Haynes, where our containers are actually in the premises. And that increases uptake, first of all. It ensures that our substance users have a safe space and drop-in center where they're actually catered for specifically. If we can encourage other districts, I'm specifically asking for Eguruleni, that we forge these so that our centers are within This also then promotes my previous suggestion of skills transfer, because if we are in the same premises, we can easily then sensitize our colleagues on management of substance users. On a universal health coverage and NHI move, we need to be futuristic even currently, and we are talking about affordable health care, and we must include the private sector. We are currently struggling with medical aids that are not recognizing the outpatient model. And if you look on a cost impact, a 6-week admission on a medical aid is nothing less than 45,000. An outpatient model is going to be a fraction of that because the accommodation part has been removed. So we are asking that you help us advocate to the Council of Medical Schemes to push and move the hand of medical aids towards this model. Then we cannot emphasize the issue of curbing relapse, making sure that we have a step-down approach. Even with government-funded inpatient programs, we need to collaborate with the outpatient model. Thanks.
All right, thank you very much. We must do away with medical aids. I know it's a controversial thing, but that's sort of a response to that question. I know we may not agree with other members here, but I'm the chair, so I can get to say it. You know. Let's take is it number 6?
Okay, good day and thank you, Chair. And through you, my name is Tsidiso Barwe. I'm from research. Tsidiso.
Baloi.
Barwe.
Oh, Barwe.
Yes,
All right.
I'm from a research and policy development unit in the Office of the Premier. So mine is very simple. I'll try to summarize everything in a minute that you have allocated. How do you bring, like in board, the academic institutes or maybe the research institutes to deal with the mental health issues? Because, for example, I know there's a program at Bara, they call it VIDA. Like under VIDA, they have a study which is longitudinal, whereby they can track these people, the victims of this mental health. And then whereby now they can easily pick up those who are more suicidal, because when you check the study of suicide, it says that those who commit suicide, they at least attempted it at least three times or more before they actually did it. So that with those programs, whereby now you are doing a clear and robust research on the field, you can easily pick up those issues. And then now there will be a potential overlap to underlying issues, or maybe the confounders, whereby maybe there are drugs involved, or maybe a dysfunctional families, whereby now you can bring in board other parties, like maybe the likes of a DSD. So I think in a minute, it's fine. We'll continue again when I get another time. Thank you, Chef.
All right, thank you very much. Number 7.
Oh, afternoon. My name is Moses Mahlangu. I'm from North Gauteng Mental Health Society. I just wanted to touch on the issue of prevention, because I heard that during the presentations I saw the mentioning of expanding wards and medication. Remember, there's, during her presentation, she mentioned that there's 17 mental health organizations or societies and other NPOs around our communities that are not getting funding, that are not getting support. So I know that there's NGC team members that are being appointed, rendering services around some NPOs, but their only focus is on special care centers and residential facilities. So apart from that, there's the issue of prevention should start from those NPOs that are there in the communities that are not getting funding, especially with our social workers. We've got social workers who are rendering services as we speak without getting any funding from health department. So we do public education services. So we do family support services, we do support groups, and any other social work related service in our communities. So what I'm suggesting is that we need to ensure that prevention can be our solution. And the late payment of subsidies, again, it's a problem in our NGO sector. Thank you.
Okay, thank you very much for that. So let's take number 8. Is it number 8, isn't it?
Thanks, colleagues. Molvitso ke Mojalefa wa Magata, Sedibeng District Health Services. Chair, I only wanted to emphasize on the issue of the municipalities, because I think it's a very important aspect that needs to be attended to, and getting support, because health cannot do everything on its own. Why I'm raising this, Chair, in view of what our colleague raised about a child with autism, is that this is a common problem that almost all our NGOs are struggling with, where the municipalities have these requirements. Sometimes if it's not a fire hydrant that is needed, where some of these NGOs have to raise in excess of 3 million just to install a fire hydrant in the facility. And the reality of the matter is that none of the NGOs have that amount of money, let alone issues of rezoning and all those types of things, which then unfortunately then places a difficulty, because when the NGCT teams that I have been spoken about, when they do then these assessments, then the NGOs will constantly be found not to be compliant, not because they don't want to comply, but because they just don't have the resources or the money to actually get the document. So I think when our sister departments come to the party, I know the MEC mentioned 4 departments, but I think our local government stakeholder, I think it's as critical to ensure then that they are able to come to the party and see how best to support, so then that as health assesses and is able to ensure then that the NGOs themselves are well supported, and where there are opportunities are supposed to waiver some of the costs or things like that, so then that they can be supported. Because I don't think health on its own, with its own budget, I don't think it will be able to subsidize to the point where it is able to cover all those requirements that sometimes the municipalities are requiring. Thanks, Chair.
All right, thank you very much. But have we interacted at that level? Have we, in a way, formulated ourselves to present what you are submitting?
We had an engagement with them, was it last month? Last month in Tshwane. And Chair, to be honest with you, at least our colleagues in Tshwane, what they have indicated in that particular sitting was that the NGOs will have to, unfortunately, find sponsors, which we said which we felt that it cannot be, Chair, that when they are coming to the table and they are saying we want to comply, but we just don't have all the monies and everything that is required at that level. And our colleagues are there in these meetings and they are saying, unfortunately, they have to source for sponsorships. And it's a very difficult situation. As I'm saying, it places health in a difficult situation, because it is expected to assess and to monitor these NGOs. And unfortunately, the reports quarterly, they always come back the same, because where will they have the 3 million if we go back the next quarter? When they go back the next quarter, the money is just not there.
Maybe we must do it differently. I mean, municipalities across the board will have a department of health, isn't it? So you have got a councillor representative in the form of an MMC. So maybe we should designate strategically those persons to be the one that represents these views in council, because I suspect that it might require some consideration by council, because if it's an official to official interaction, it falls on the weight of a bureaucracy. It becomes a bureaucratic exchange, whereas it could be carried as a political point of discussion, requiring that kind of a resolution. So a solid resolution on exemptions, because municipalities do exempt. I mean, for instance, churches, some of the churches are exempted, you know. So I think maybe let's style it differently. We don't lose it out of the agenda, but we present it or model it differently for presentation. But it's something that we can explore, you know. I know I will also represent it because at least we do interact with political actors in other spaces. It's something that we may need to raise up. But thank you very much. Let's take number 10. Number 9. Okay, we're fine. We're all fine. All right, thank you very much. I think that's the discipline, you see. I know second rounds, people would have, you know, become more comfortable and they might be more expressive. And that's why we allowed for the second round of engagements. Final remarks from the department and we close. Any final remarks, including the issues that I may have raised? Those that you can't respond to, commit. Put your necks on the block. So that as part of our, yeah, we want that. We don't want, this is not a dinner date where you tell each other sweet pleasantries and outside of that date, you don't actualize anything. You know, so you must put your necks on the block or on this because we are going to agree with the stakeholders here when we're reconvening. So we can agree that we allow you 6 months, but in between the 6 months, we want to see inputs. Whether you have interacted, followed up on some of these issues. That's how we want to do it. So let me hand it over back to you, Doctor.
Okay, thank you so much, Chair. I just wanted to comment on this. Oh, I should stand. Thank you. Yeah, there was a comment on slide number 8 regarding Cullinan. So I would like to comment on that. So Cullinan is currently, actually the capacity for Cullinan is 300 beds. So currently they are at 165 and they've been engagement with infrastructure as well. So assessments are done in other wards that need some minor renovations. So as soon as those are completed, Cullinan can be able to expand their capacity. I think they can be around 800 beds that can be available, more than what is there currently at Cullinan. And again, indeed, there are users that are actually meeting the requirements for being placed at the residential NGOs, and that is a process that we are also looking at to identify those and looking at their physical addresses as well, take into that consideration. Then we'll see if some placement can be done. The other part that I'd like to comment on was on the post, which was raised that, you know, more strengthening was done at the district level, of which there were more posts that were created and a lot of appointments took place. I would like to emphasize the fact that the same MDT officials that are at the district are also mandated within their district to support the hospitals. So we've noted some of the gaps where in some of the hospitals, OT or rehabilitation programs are not implemented. So we'll take that further to engage with our colleagues at the district, because in each and every team, there are occupational therapists appointed so that they can also support the hospitals, making sure that there's program in place, teaching them how to implement that program so that there can be that continuous rehabilitation. So I would like to say that in as much as there are more staff at the district, however, there should be that working together so that we can bridge the gaps that are available at the hospitals as well. Thank you.
That is le bebara moja morao ki khoshi. Oro zananda debit.
Thanks, Chair. I think a lot of the issues have been responded. I stood up when I was introduced. I thought I don't have to stand up again. But we thank colleagues for the issues raised. But one issue in particular that maybe we need to engage further on is the one about clinics giving 6 months turnaround time for appointments. I think we'll have to take the specifics around that and revisit that particular matter. But the other issues, we have taken note of the proposals, and they'll form part of the discussions as we move forward, including what you have said, that you said you'll raise at other platforms. But I think it's a matter that you can also put as part of our submission for the Provincial Health Council to consider, because you have the MEC and MMCs there to see how they can assist in dealing with that matter. But the rest of the issues, Chair, I think we can break them down further, especially what you are raising about the budgetary constraints with regards to the demographics per district. It will form part of the expanded presentation that we'll put forward. Thank you very much.
That is Lebe.
No, thank you, Chair. I think then the colleagues have covered most of what you've said, Chair, and we note the recommendations, and as the team, we will go back and look at those recommendations and then plan around them to ensure that then we also contact the stakeholders that have well recommended those, and then we can move forward. But we accept all the recommendations, Chair. We are going to look at them. And then the issue of, is it Member Evans on, is the decanting, or was it, yeah. What happens, there is a team that sits every Friday with hospitals, and then they are able to discuss on those patients that have to be decanted to the contracted care. So that's how it moves. And then those beds then gets made available and those patients move so that we create space in the current institutions. Thank you.
We done? All right, thank you very much. I know there are other comments, questions that may not have been adequately responded to, including renovations in some of the facilities. We'll need to have more detail around that so that we can make stakeholders appreciate the overall thought plan of the department in strengthening the ability of the system to respond to the burden. But I think allow me at this point to thank each and every one of you. We really want to appreciate your mainstay and your resilience to engage. These are not easy engagements, you know. Quite painstaking because most of us would be affected by mental health challenges. And I think I like what Madame Patel says. Well, it's not only just about health, because it's an affliction that affects the individuals, families, communities, but overall, a nation. And that is why it's mostly important that we make these reflections earnestly and not as a procedural process, you know, but rather earnestly, so that we can fashion necessary responses and interventions to the problem in a deliberate, well-coordinated fashion, not a passive one, but one that appreciates the extent of the problem and how it implicates the mental health being of every one of us. Because it's harrowing, you know, having to come across mental health patients not being assured of the kind of a cushion that is being rendered to them out of these treatment regimes or processes. And so as we live here, I think let's take stock, let's reflect ourselves. Because we usually have a superficialities in how we are stationed. But beyond that, we are ordinary men and women of society. Elsewhere, somebody states that the measure of any progressive society is how it treats its most vulnerable. Those who fall into the category of mental health burdens that we contend with as a country do not do so voluntarily. those who fall into the trappings of substance misuse or abuse do not do so willfully, but it is the materiality of situations that they find themselves in. And they require that the rest of us who are better off lend a hand. And I think that's the spirit that should govern all of us as we live here. But I'd request that Member Hicklin to just do the vote of thanks quickly.
Thank you so much, Chair. Thank you to our representatives from all the different districts, from all the different health facilities, from all our NGOs, from all the participants who came through today to share your stories with us as a portfolio committee committed to ensuring that your concerns become our reality. We are committed to ensuring that we listen to what you have said and we do our best to work with you to action them. We are not a committee of silent bystanders. One thing I can tell you about the Health Committee, the Health Portfolio Committee in the Gauteng Provincial Legislature, is we are some of the most committed people I have ever had the privilege of working with. And we really and truly, together with our support staff and our researchers, put into action that which we talk about. And when I say to you, you have our email addresses, you certainly have a means by which you can contact us. I really mean it. I'm speaking on behalf of the committee when I say to you, we are offering a hand to work with you, not against you. We will do everything in our power. We made a commitment to a focused intervention study on mental health issues, and we will continue to ensure that the findings of this focused intervention study finds its way into practical applications. Please continue to engage with us. This is one public participation. It's the beginning of a process. It's not the end of a process. Thank you to every single one of you who took time from your day to join us. We really appreciate it, and we give you our word it's not going to be the last. Thank you, thank you, thank you.
All right, thank you so much, Member Hicklin. We are officially adjourned, but just a quick announcement. Lunch is going to be served, but there's a request that we remain where we are. Where's the lady? Man on Dumiso. Is that the arrangement? So, what is, just explain it.
Thank you, Chairperson. Everyone should remain seated. You'll be served from your seats. Thank you.
And then we are also going to compile a report out of everything that you have said, which report we are going to share amongst all of you. I think those of you who had not given us your contacts, you can just come up front. But the other formally invited stakeholders, or those that responded, will have your details. But I'm just saying, for those that would have just saw the advert and decided to come, so that we ensure accountability on all of these engagements and accountability. We'll request that you come up front so that you register your details, so that when we release the report, it gets to be circulated amongst all of you. And we'll share the very same report with the department and then time it. We usually give them about 7 to 12 months. We'll make that determination so that when we reconvene, we follow up on some of the issues that you will have raised. I hope that is in order. But thank you very much once more. We are adjourned, isn't it? Yeah.